combine grayscale morphology, Doppler assessment, and systematic pelvic survey rather than rely on imaging feature alone. Ladies and gentlemen, this brings us to the end of this presentation. This is advanced ultrasound. It's no longer the ultrasound where you just say rush, say mass, write the report, send the patient away. This is a characteristic masterclass ultrasound piece of a lecture where we are going into the depth of ovarian masses, how to differentiate them, so that we don't cause unnecessary panic, we don't cause unnecessary expenses, we also don't have to cause unnecessary complications to the patients. Ladies and gentlemen, I thank you so much. Don't forget to comment, like, and share our educational content. Let's meet again in the next episode. Thank you. Silent uterine scars. Identifying niche dehiscence risk in routine post-cesarean scans. Let's talk, ladies and gentlemen. Let's talk. Do you know what are called niche dehiscence risks? Do you know what are called niche dehiscence risks in routine post-cesarean sections? Have you ever heard about them, or have you ever came across such where you have got complications related to cesarean sections, or you overlook them? So let's talk. Let's have this conversation. So we investigate the structural integrity of the lower uterine segment by isolating subtle sonographic markers of niche dehiscence. We differentiate between benign thinning and high-risk defects using transvaginal sagittal planes. By correlating residual myometrial thickness with the clinical risk factors, we refine diagnostic accuracy for post-cesarean scanning and improve patient management protocols. So, the medical mystery hook. A routine post-C-section scan might look normal at the first glance, but the hidden danger could be lurking in the shadows of the uterine wall. Niche dehiscence or silent scarring is often overlooked during follow-up imaging, yet it poses significant risk for future pregnancies. We are diving deep into how to identify these subtle defects before they become a medical emergency. So the urgent safety hook. Did you know that an incomplete healing of a uterine incision can lead to life-threatening complications later on? Many practitioners miss the early warning signs of niche dehiscence during standard routine checkups. In this presentation, we reveal the specific markers you must look for in post-cesarean scans to ensure long-term patient safety and reproductive health. Ladies and gentlemen, let me ask, do you check for these? You see how critical the history of a patient matters in medical ultrasound imaging. So the clinical expertise hook. Mastering the identification of uterine niches is a critical skill for modern sonographers and radiologists in 2026. These silent scars are more common than you think, but their diagnostic criteria are frequently misunderstood. We will break down the latest imaging protocols and risk factors that help differentiate a stable scar from a high-risk dehiscence. So now, the learning objectives of this presentation. So by the end of this lesson, you should be able to understand the anatomy of the cesarean section scar, define a routine niche, which is called an ischio-mosile, recognize normal and abnormal post-cesarean scar appearances, identify ultrasound features suggestive of scar dehiscence, measure the residual myometrial thickness RMT, understanding the clinical implications of uterine scar defects, and produce a structured ultrasound report. So at the end of this, I've also put 6 quiz questions for you to internalize what we have been learning. So now, introduction. With the cesarean delivery rates increasing worldwide, sonographers encounter post-cesarean uterine scars almost daily. Most scars heal normally, but some develop niches which are called ischemosials or partially dehiscence, which may remain clinically silent for years. So you can see here what we have here. So that is a scar niche there, a scar niche there. So you can see here now what we have here is an ischemosial that is formed there. So these defects may later contribute to chronic pelvic pain, post-menopausal spotting. Secondary is infertility, cesarean scar, ectopic pregnancy, placenta accreta spectrum, uterine rupture during future pregnancies. Routine pelvic ultrasound offers an excellent opportunity to detect these abnormalities before complications occur. What is a uterine niche? What is a uterine niche? A uterine niche or ischemosal is an indentation or triangular defect in the myometrium at the previous cesarean scar that communicates with the endometrial cavity. It forms because of incomplete healing of the lower uterine segment, also known as a cesarean scar defect or ischemosal or scar pouch or a scar niche. So normal scar healing, so you can see here, there's a normal scar healing there, there's a normal scar healing there, as you can see. So a normal scar demonstrates smooth anterior uterine contour, uniform myometrium, no fluid collection, no indentation, thick residual myometrium, intact serosal line. Why do niches develop? Risk factors include surgical factors, low uterine incision, poor surgical closure, single layer closure, infection, hematoma formation, patient factors, obesity, diabetes, smoking, multiple cesarean deliveries, retrovated uterus, or poor wound healing. So the clinical symptoms. Many women have no symptoms. Others may complain of brown spotting after menstruation, intermenstrual bleeding, dysmenorrhea, dyspareunia, infertility, or pelvic discomfort. Ultrasound technique. So preferred examination is the transvaginal. Best timing early proliferative phase, days 5 to 10. Small amounts of intracavitary fluid improve visualization. So scan planes, sagittal, transverse, oblique if necessary. So you can visualize the niche there. You can visualize the niche there. Sonographic appearance of a niche. Typical findings include triangular defect, most common appearance, semicircular defect, rounded pouch, wedge-shaped indentation points towards the bladder, cystic defect, fluid-filled cavity or irregular defect seen after infection or repeated cesarean sections. Ultrasound measurements. Always measure the length, which is the superior inferior dimension. So this one, that's the length of the niche. You can see this one. That's what you're supposed to measure. Guys, have you been measuring this? Did you know about this? With transverse dimension, then you have to measure the transverse dimension, length and the width, and the depth from endometrial surface to the deepest point. So from the endometrial surface to the deepest point. So those are the measurements that you're supposed to make. So the residual myometrial thickness, you must measure that one. The residual myometrial thickness. The residual myometrial thickness. Distance from the niche apex to uterine serosa. This is the most clinically important measurement. You see, guys, these areas, this tiny thin area is the one that I'm talking about that you are supposed to measure. This is the most critical. So residual myometrial thickness, RMT, interpretation above 3.5 millimeters, generally measuring 2 to 3.5 millimeters, intermediate concern. Sorry, so let me come again from the residual myometrial thickness measurement. This one, that's the one that I said is very, very critical. So you must, the interpretation of residual myometrial thickness is as follows. So if the measurement is above 3.5 millimeters, is reassuring. So nothing much to worry about. Then if it's 2 to 3.5 millimeters, so it's an intermediate concern. But if it's less than 2 millimeters now, there's a higher risk. That's the higher risk now. Associated with scar dehiscence, future uterine rupture, cesarean scar pregnancy, or placenta accreta spectrum. So you see now where it gets interesting. So the residual myometrial thickness, you have to measure that one. I don't know if some of you guys are measuring this. This is now what I said. The distinction between the university learning and the theory learning and the practical aspect. So this is the clinical aspect that we are now learning. So that's the transition. Understand the transition that we are now moving towards. So features suggestive of scar dehiscence. Important findings include extremely thin myometrium, large niche, myometrium interruption, serosal bulging, fluid collection, blood products in the niche, communication in the endometrial cavity, ballooning anterior lower uterine segment. So those are the sonographic signs of a scar dehiscence. So color Doppler assessment evaluation, scar vascularity, hypervascular granulation tissue, abnormal neovascularization, cesarean scar ectopic pregnancy, arteriovenous malformation, normal healed scars usually show minimum vascularity. So the differential diagnosis: cesarean scar pregnancy, adenomyosis, cervical anabothine cyst, endometrial polyp, retained products of conception, uterine rupture, or hematoma. So potential future pregnancy risks: women with severe niches are at increased risk of cesarean scar ectopic pregnancy, placenta previa, placenta accreta spectrum, placenta increta, placenta pancreta, scar dehiscence, uterine rupture, abnormal placentation, and preterm delivery. So the structured ultrasound report that you're supposed to produce when you see a niche. Findings: the uterus is anteverted. A triangular hypoechoic defect is demonstrated within the anterior lower uterine segment at the previous cesarean scar. The niche measures 8 by 6 by 5 millimeters in 3 dimensions. Residual myometrial thickness measures 1.8 millimeters. No surrounding collection is identified. Color Doppler demonstrates minimum vascularity. The bladder interface remains intact. So the impression: post-cesarean uterine scar niche is chemosal with markedly thinned residual myometrium, increasing the risk of future scar-related obstetric complications. Correlation with obstetric history and specialist gynecology review is recommended. So this is how you write a simple report. The uterus is anteverted. A triangular hypoechoic defect is demonstrated within the anterior lower uterine segment at the previous cesarean section. The niche measures 8 by 6 by 5 millimeters. Residual myometrium thickness measures 1.8 millimeters. No surrounding collection is identified. Color Doppler demonstrates minimum vascularity. The bladder interface remains intact. So the impression: post-cesarean uterine scar niche is chemosal with markedly thinned residual myometrium, increasing the risk of future scar-related obstetric complications. Correlation with obstetric history and specialist gynecology review is recommended. So the key reporting checklist: always comment on number of previous cesarean sections, the scar location, the scar morphology, the niche presence, niche dimensions, residual myometrial thickness, serosal integrity, the color Doppler vascularity, adjacent fluid, then bladder interface or associated pelvic abnormalities. So the clinical POs: Every woman with a previous cesarean deserves careful assessment of the scar. Transvaginal ultrasound is superior to trans-abdominal imaging for evaluating scar niches. Residual millimeter thickness is the strongest predictor of future obstetric risk. A large niche may explain abnormal uterine bleeding and infertility. Thin residual millimeter less than 2 millimeters warrants careful counseling before future pregnancy. Always exclude the cesarean scar ectopic pregnancy when in early gestational sac implants near the scar. So now, that brings the end of the presentation, but we need to internalize things. So I'm going to go into the quiz session. So it's just 6 questions, answers, questions and the answers. So let's proceed. So question number 1. A 34-year-old woman presents with the post-menstrual spotting 3 years after 2 cesarean deliveries. Transvaginal ultrasound demonstrates a triangular hypoechoic indentation, as you can see there, extending from the endometrial cavity into the anterior lower uterine segment. What is the most likely diagnosis? A. Adenomyosis. B. Caesarean scar niche, which is the ischemocele. C. Cervical polyp. D. Endometrial hyperplasia. So without further ado, our answer is B. Caesarean scar niche, which is the ischemocele. Explanation: a cesarean scar niche is the most common long-term complication following cesarean delivery. Sonographically, it appears as a triangular or wedge-shaped hypoechoic defect communicating with the endometrial cavity at the previous uterine incision. So typical symptoms include post-menstrual spotting, pelvic pain, secondary infertility, and dysmenorrhea. Why the other answers are incorrect? A. Adenomyosis causes diffuse heterogeneous myometrium with myometrial cysts rather than a focal scar defect. C. Cervical polyps arise within the cervical canal and are usually vascular. D. Endometrial hyperplasia causes diffuse thickening of the endometrium without an anterior myometrial defect. So let's go to question number 2. Which ultrasound measurement is considered the strongest predictor of future uterine rupture risk in women with a cesarean scar niche? Which ultrasound measurement is considered the strongest predictor of future uterine rupture risk in women with a cesarean scar niche? A. Endometrial thickness. B. Scar width. C. Residual millimeter thickness, RMT. D. Cervical length. So which one is the correct answer? So the correct answer is residual myometrial thickness, RMT. The explanation: residual myometrial thickness, RMT, is the distance from the deepest point of the niche to the uterine serosa. It reflects the amount of remaining muscular support over the scar. General interpretation: above 3.5 mm is a low risk. 2 to 3.5 mm, that's intermediate concern. Less than 2 millimeters, increased risk for scar dehiscence, uterine rupture, cesarean scar pregnancy, and placenta accreta spectrum. The thinner the remaining myometrium, the greater the potential obstetric risk. So let's go to question number 3. Which ultrasound finding most strongly suggests a well-healed cesarean section scar? A large fluid-filled pouch. B. Thick uniform anterior myometrium with an intact serosal line. Thick uniform anterior myometrium with an intact serosal line. C. Triangular hypoechoic defect. B. Bulging lower uterine segment. Which ultrasound finding most strongly suggests a well-healed cesarean section scar? A. Large fluid-filled pouch. B. Thick uniform anterior myometrium with an intact serosal line. C. Triangular hypoechoic defect. D. Bulging lower uterine segment. So the correct answer is B. Thick uniform anterior myometrium with an intact serosal line. Explanation: a normal post-operative scar demonstrates smooth anterior uterine contour, intact serosal surface, uniform myometrium, no niche, no fluid collection, adequate residual myometrial thickness. These features indicate satisfactory healing of the lower uterine segment. Question number 4. Why should color Doppler routinely be used when evaluating a cesarean scar defect? A. To measure fetal heart rate. B. To assess ovarian reserve. C. To evaluate scar vascularity and exclude cesarean scar ectopic pregnancy or abnormal neovascularization. D. To diagnose endometriosis. So the correct answer here is to evaluate scar vascularity and exclude cesarean scar ectopic pregnancy or abnormal neovascularization. So the explanation, color Doppler provides valuable information by assessing vascularity within the scar, detecting abnormal neovascularization, identifying hypervascular cesarean scar pregnancies, evaluating granulation tissue or arteriovenous malformations. A normally healed scar generally demonstrate minimal or absent vascularity. Question number 5. A patient with a known uterine niche becomes pregnant. Which complication carries the highest clinical concern during an early pregnancy? A. Ovarian torsion. B. Placenta previa only. C. Cesarean scar ectopic pregnancy. D. Hydrosalpinx. A patient with a known uterine niche becomes pregnant. Which complication carries the highest clinical concern during early pregnancy? A. Ovarian torsion. B. Placenta previa only. C. Cesarean scar ectopic pregnancy. D. Hydrosalpinx. So the correct answer is C. Cesarean scar ectopic pregnancy. The explanation being implantation within a cesarean scar is a rare but potential life-threatening condition. Complications include massive hemorrhage, uterine rupture, placenta accreta increta spectrum, emergency hysterectomy, maternal morbidity. Whenever an early pregnancy sac is identified near a previous cesarean scar, careful evaluation is essential to exclude a scar ectopic pregnancy. Question number 6. Which combination of ultrasound findings is most suggestive for uterine scar dehiscence? Thick myometrium with a smooth contour, homogeneous endometrium with a normal cervix, large scar niche, residual myometrium thickness less than 2 mm and anterior lower uterine segment bulging. D. Small ovarian cyst with posterior acoustic enhancement. Which combination of ultrasound finding is most suggestive of uterine scar dehiscence? A. Thick myometrium with a smooth contour. B. Homogeneous endometrium with normal cervix. C. Large scar niche. Residual myometrium thickness less than 2 mm in anterior lower uterine segment bulging. D. Small ovarian cyst with posterior acoustic enhancement. So the correct answer is C. A large scar niche, residual myometrium, thickness less than 2 mm in anterior lower segment bulging. The explanation being ultrasound features concerning for scar dehiscence include large triangular or irregular niche, residual myometrium thickness less than 2 mm, marked thinning of the anterior uterine wall, bulging of the lower uterine segment, fluid or blood within the defect, disruption of normal myometrium continuity. These findings indicate poor scar integrity and increase the risk of uterine rupture in future pregnancies. Prompt referral to a gynecological or maternal fetal medicine specialist recommended for further assessment and counseling. So, ladies and gentlemen, this brings us to the end of our quiz session. So, the key learning points are transvaginal ultrasound is the preferred modality for evaluating cesarean scar niches. Residual myometrial thickness, RMT, is the most important measurement for assessing future obstetric risks. A triangular hypoechoic defect communicating with the endometrial cavity is a characteristic of an ischemocele. Color Doppler helps evaluate scar vascularity and excludes cesarean scar ectopic pregnancy. An RMT less than 2 minutes is associated with higher risk of scar dehiscence, uterine rupture, and abnormal placentation. Standardized assessment and reporting of scar morphology, measurement, and vascularity improve clinical decision making and patient outcomes. So I hope the message has been delivered home, ladies and gentlemen. So from now on, I think you are now better informed about these scar niches. You are going to pay due diligence when you are scanning them. Please do, because you can save a life and reduce a lot of complications. Thank you so much for your time, ladies and gentlemen. Don't forget to subscribe, share this educational content. Let's grow the community together. Let's be interactive. Let's chat. Tell me the areas of improvement that you need. If there are any areas that you need us to improve, please comment on that, and I will accept that, and we will work on you. We are here to tailor make, transfer the knowledge to you. My role is to transfer the knowledge to you. So I must not choose what I have to tell you, but you must tell me what you want me to teach you, or what exactly bothers you in the practice of medical ultrasound. Then I go straight to that. Thank you so much. Enjoy the rest of your day. Let's meet again in the next presentation. Bye. What if a single Doppler ultrasound could reveal whether the uterus is truly ready for implantation? In the next few minutes, you will discover how uterine artery Doppler flow may provide valuable clues about endometrial receptivity, and why this assessment is becoming an important part of modern infertility evaluation. Every year, millions of couples struggle with infertility, yet one critical factor is often overlooked: the blood supply to the uterus. Today, I will show you how uterine artery Doppler helps us assess uterine perfusion, interpret key Doppler indices, and understand what these findings may mean for fertility treatment and reproductive success. So let's delve more into this subject matter. Uterine artery Doppler in infertility, assessing endometrial receptivity in the blood flow. This is a comprehensive presentation that I'm going to make to you. I need you to listen very carefully and never miss a single aspect of this presentation, because it is very, very critical in the practice of radiology and gynecology in general. So, I want you to appreciate the uterine artery Doppler in infertility. We are no longer just talking about the artery as an anatomy, but we are talking about an artery as an application in fertility issues. It's now an application. We are moving beyond the normal anatomy that you know. It's an application towards a process of fertility, process of how does it work? Which information does it give? People, they know it mostly when it comes to screening for preeclampsia. But we are now going beyond the screening for preeclampsia. We are going a step notch beyond that. So, uterine artery Doppler in infertility, assessing endometrial receptivity in the blood flow. So, what are the key learning objectives in this presentation? By the end of this presentation, you should be in a position to explain uterine artery blood supply, understand the uterine artery Doppler physics, perform a standardized examination, interpret the Doppler indices, understand the menstrual cycle changes, and correlate these findings with infertility, recognize the limitations, apply findings in IVF and a fertility practice. So now, why blood flow matters? Why blood flow matters? Successful implantation depends on three major factors, which are healthy embryo, receptive endometrium, adequate uterine blood supply. Poor uterine perfusion may contribute to reduced implantation rates, thin endometrium, recurrent implantation failure, some cases of unexplained infertility. So, important clinical note: uterine artery Doppler should not be used alone to determine fertility potential. It is one component of a comprehensive infertility assessment. So, let's recapture the anatomy of the uterine blood supply. So, the Blood reaches the uterus through the internal iliac artery, then it goes to the uterine artery, then it goes to the arcuate arteries, then to the radial arteries, the basal arteries, the spiral arteries, then finally to the endometrium. The spiral arteries are primarily responsible for supplying the functional layer of the endometrium where implantation takes place. So the functional layer of the endometrium, that's where the implantation takes place. Then the basal layer is the support, the anchorage of the pregnancy itself. Role of the endometrium. This is very critical, ladies and gentlemen. A receptive endometrium requires good oxygen delivery, nutrition supply, angiogenesis, appropriate hormonal response, low vascular resistance, healthy spiral arteries. Without adequate blood supply, implantation may be less likely. What is uterine artery Doppler? What is a uterine artery Doppler? Uterine artery Doppler evaluates blood flow velocity, the vascular resistance, the pulsatility, the perfusion. It provides an indirect assessment of the uterine vascular resistance. So, the Doppler ultrasound principles, the color Doppler shows vessel location, power Doppler displays low velocity blood flow with greater sensitivity. The spectral Doppler now measures peak systolic velocity and diastolic velocity, pulsatility index, and the resistance indices. So you can see that all the Dopplers are coming in the assessment for fertility. They are now having an application. This is now an application. It's just beyond just seeing a fetus, just seeing a fibroid. It's now having a greater clinical application. So when you are holding a probe, it can go beyond the ordinary, beyond what you know on a daily basis. So the examination technique: patient preparation, empty bladder, the lithotomy position. These you already know. These are the basic, these are the fundamental things. Explain the examination to the patient. Then probe, transvaginal probe, preferably a frequency 5 to 9 megahertz. So as you can see here, this is how the waveform appear like. I've done that in the previous section to show you how the waveform of a normal non-gravity uterus appear like. And you can see that it has got a slightly higher, it has got a higher resistance compared to the pregnant one. Because you can see here what you have, the peak, the peak, the highest point of the wave, this one, that's the peak systolic velocity. Then this other depression that you have here, that's the end diastole, the end diastolic velocity. And there's also a notch. You see this depression that you're seeing, that's a notch there. So a notch represents that the vascular channel is not as open as it is when someone gets pregnant. So when someone gets pregnant, the vascular channels, all the blood supply that is going towards the womb or the uterus, it dilates, it becomes less resistant. More channels open, what we call angiogenesis. More blood vessels they open, and the existing vessels they dilate so that they feed the incoming implantation, or the fetus that is coming in. Then it needs enough oxygenation in nutrition. So because this was non-gravity, that's why we have this relatively higher resistance to flow. That's the normal in a normal uterus. So now, how do you locate the uterine artery itself? The steps: visualize the cervix. You should identify the side wall. You must activate color Doppler on the side wall of the uterus, just closer to the cervix, around that area of the os, on the side walls. That's where you identify in a non-gravity uterus. Activate color Doppler, locate uterine artery crossing the external iliac vessels or near the cervico-uterine junction. So that's the standard when you are dealing with a non-gravity uterus, the cervico-uterine junction. So place Doppler gate angle correction, ideally less than 60 degrees. So we are saying that the Doppler angle, it should be ideally less than 60 degrees. So the spectral waveform, a normal uterine artery waveform demonstrates a rapid systolic upstroke, the one that I was showing that peak there, and the continuous diastolic flow without the gaps. It must not be absent or reverse. So smooth waveform, low resistance during the implantation window. So when implantation now happens, we expect now the vascular channels to open, as I said, then the resistance decreases. Those are the Doppler indices that we use. We do have what is called the power utility index, PI. So with the modern high-end machines, you don't calculate this one. The machine automatically does, as long as you know the technique on how to identify the uterine artery itself, and then how to set your gauge, the angle of insonation, and then measure your waveform nicely, and then the machine will do the rest. So the power sensitivity index, PI, is given as the peak systolic velocity minus the end diastolic velocity divided by the mean velocity. Mean velocity it simply means that is the addition peak systolic velocity plus end diastolic velocity. If you add the two, then you divide by 2. That's the mean velocity. So it reflects downstream vascular resistance. So the higher the PI, the positive index, the higher the resistance and the reduced perfusion. So we are saying that when there is a higher PI, we would higher resistance. And we also would reduce what? Perfusion to the uterus. So you can see now the dynamics that is happening. So the moment that you start to see that there is a higher PI, it means that the perfusion to the uterus is going to be reduced. So we are starting to get a picture that implantation can be a problem because of the low perfusion that is going to ensue from the higher positive index. So the resistive index, which is RI, is calculated as follows: peak systolic velocity minus the end diastolic velocity divided by the peak systolic velocity. So also measures resistance. So higher RI indicates greater vascular resistance. Higher RI, it indicates greater vascular resistance. So they are almost the same, but PI is more accurate, more predictable than the resistive index. So the peak systolic velocity, PSV, is the highest blood flow during systole. I have shown you the peak. Then the end diastolic velocity, EDV, blood flow during diastole. Lower EDV generally reflects higher resistance. So the menstrual cycle changes phase in the blood flow. So the menstrual phase, we deal with moderate blood flow. Then with the follicular phase, we deal with blood flow that's increasing. Then during the ovulation stage, we with a higher blood perfusion, so meaning that the resistance will be low. Then mid-luteal phase, the maximum receptivity, that's where we with maximum blood flow. Then the late luteal phase, we with the resistance, it will start to increase now in the late luteal phase because implantation has failed. So we now have resistance that is now chipping in. So the cycle, the way we are worried about the luteal phase, that's where we should have got the maximum receptivity. So the mid-secretory phase, implantation window often shows lower uterine artery resistance than earlier in the cycle. So you can see the dynamics of the flow that is happening. So if you know the cycles, you really have to track and know at which stage are we, what about is are we likely to get. So that information alone can give you a pointer to say we have got a chance of fertility here, we've got a chance of implantation, or we might not have. So now, the endometrial receptivity. A receptive endometrium usually demonstrates, when we're talking about a receptive endometrium, we're talking about an endometrium that is with the capability for implantation, where a fetus can implant and grow within without causing miscarriages and issues, or without failing to conceive. So an appropriate thickness, a trilaminar appearance around ovulation, adequate vascularity, good spiral artery perfusion, and favorable hormonal environment. So the clinical applications, useful in unexplained infertility, IVF assessment, recurrent implantation failure, thin endometrial evaluation, research protocols, and uterine perfusion studies. So Doppler findings that may suggest reduced perfusion. Potential findings include elevated PI, elevated RI, reduced diastolic flow, poor endometrial vascularity, reduced spiral artery flow. These findings should always be interpreted alongside with clinical history and other fertility investigators or investigations. So you can see now where we're going. The Doppler findings that may suggest reduced perfusion. Potential findings include 1. Elevated PI, 2. Elevated RI, 3. Reduced diastolic flow, 4. Poor endometrial vascularity, 5. Reduced spiral artery flow. Causes of increased uterine resistance. What are some of the causes? What is happening? The common causes include fibroids, adenomyosis, endometrial pathology, chronic endometritis, pelvic inflammatory disease PID, previous uterine surgery, smoking, advanced maternal age, or vascular disease. IVF applications. Research suggests uterine artery Doppler may help evaluate uterine perfusion before embryo transfer. Complement assessment of endometrial development. Support individualized fertility treatment planning. It should not be used as the sole criteria for proceeding with or cancelling embryo transfer. So the limitations. Uterine artery Doppler does not directly measure implantation, cannot demonstrate embryo quality, is operator dependent, also varies across the menstrual cycle, should be interpreted with clinical context. So it should be within the clinical context that you are interpreting it. So you should have the history of the patient. So these are some of the common pitfalls. Avoid incorrect vessel identification, excessive probe compression, large Doppler angles, measuring during uterine contractions, poor spectral tracing, single waveform interpretation. So you should measure a number, 3 or more peaks, and take an average. Don't just measure one peak and say, we have it. Always average multiple consistent waveforms when possible. So the reporting example, how do we report? How do we report on these Dopplers? So the technique, transvaginal ultrasound, the bilateral uterine artery color, and spectral Doppler evaluation. So the findings, symmetrical uterine arteries identified, normal forward diastolic flow, PI and RI recorded bilaterally, endometrial demonstrate expected appearance for cycle phase. So the impression, uterine artery Doppler demonstrated vascular resistance within expected limits for the clinical context. correlate with the menstrual phase, endometrial morphology, and the complete infertility evaluation. So, I have said a lot. You should internalize these things and master these things. What are your take-home messages today? Uterine artery Doppler provides insight into uterine perfusion. Blood flow changes throughout the menstrual cycle. Lower vascular resistance is generally associated with improved uterine perfusion during the implantation window. So Doppler findings should complement, not replace, other infertility assessments. A standardized examination technique improves reproducibility. So there are some texts which are not so obvious to everyone, some information that you might need beyond what we are talking. So those who have got the zeal and the will to learn and read, these are some of the references that I have suggested for you that you can also read and get some information there to broaden your horizon. Go beyond the textbook things, go beyond the academic things, go beyond any other expectations, then start to think as a person who is a practitioner, person who is the mission, person with a purpose. Then think beyond the ordinary. So you can go and read the International Society of Ultrasound in Obstetrics and Gynecology, ISIOGO, Guide on Gynecological Ultrasound, the European Society of Human Reproduction and Embryology, ESHRE, Recommendations in Infertility Evaluation, American Society for Reproductive Medicine, ASRM, Practice Guidelines on Infertility Assessment. Then the recent peer review on uterine artery Doppler and endometrial receptivity 2024 to 2026. The problem of most sonographers, they want to work within the frameworks of what has been said before by their predecessors, which is not correct, because if their predecessors were limited, you are also limited. Do not wait for the clinicians to bring things they need. Show them your skills, what you can do, and also tell them what can be done. Go and have a discussion with your gynecologist. Guys, do you know that if you are using ultrasound, the spectral Dopplers, power Doppler, color Doppler, they can assist us in assessing the vasculature of the uterus itself using the uterine arteries. And then you can explain the merits in terms of fertility assessment tracing. Then you can start to implement it yourself and then recommend it to the doctors. Meaning to say that you have employed yourself. More clients are going to come to your center because you've opened an avenue for them. Imagine a doctor is seeing, on average, let's say maybe seeing 20 patients with fertility issues per month. Then automatically, when you marry your capabilities to what that doctor wants, it's going to send all those patients to your practice. Meaning to say, it's a business thing as well, besides just acquiring knowledge. So tell them what you can do, what the machines can do, you understand? And then they will refer patients to you. People, they already, most people, they will just wait for those doctors to send patients to them, because they know that I can do a pelvic sonar. Let them bring patients to me. Sell your brand. You are a brand. You are a brand. That's my take-home message to you. Thank you so much. Don't forget to subscribe to our channel. Like our channel as well. Thank you so much. Enjoy the rest of your day. Let's meet again in the next presentation. Hello colleagues, how are you doing? So today let's talk about something that is very, very different. So we are going to talk about uterine artery Doppler in infertility. So we are assessing endometrial receptivity and the blood flow. We measure the pulsatility index of the uterine artery to quantify endometrial perfusion, transforming subtle waveforms into actionable diagnostic data. By analyzing resistance patterns and notch presence, we determine if the uterine environment is hemodynamically prepared for implantation and bridging the gap between the raw spectral Doppler signals and successful clinical reproductive outcomes.
So I'm going to just show you how a non-pregnant uterus, uterine artery Doppler appear like, because this one is going to build on the next topic which we are going to discuss, how to assess the uterine artery to assess for infertility. We're going to use the uterine artery to assess for infertility. So that's the revolution. So the problem that is here, that we have, or that people have, why does a healthy embryo sometimes fail to implant? The answer might not be the embryo at all, but a sudden issue with your uterine artery flow. So today we are diving deep into how uterine artery Doppler technology can unlock the secrets of your endometrial receptivity and finally bridge the gap between infertility and a successful pregnancy. So most people, they are not aware of how that is done. So I'm going to divide this into two sections, the practical aspect and then the theory aspect. Did you know that the uterus is a pause, or you didn't know? Did you know that the uterus is got a pause that determines fertility success? Most people overlook the importance of blood flow, but the uterine Dopplers is the revolutionary tool that measures exactly how receptivity of the lining can help to determine fertility. So I am not going to say a lot, but I need us to know that we are now entering a new era of reproductive medicine, where we can visualize fertility success before it happens by using uterine artery Doppler to assess endometrial blood flow. We can now identify specific resistant platforms that might be preventing you from staying pregnant. So we are going to break down this in the theory section. So I need you to be very patient with me on this one, so that we don't miss anything that is critical here. I hope it's going to make sense. So the fundamental thing that I want you to grasp, to understand before I build this concept, I want you to know that we are entering a new era of reproductive medicine. One way ultrasound allows to assess the environment for implantation before pregnancy begins. So it's very, very critical. That's why I just brought this to you guys. So the uterine artery Doppler gives us a window into endometrial perfusion, helping identify blood flow patterns that may influence implantation and infertility. While Doppler findings alone cannot predict pregnancy, they can provide valuable information about uterine vascular resistance and complement the overall fertility assessment. So now I need you to understand the positive index, internet Doppler waveforms, and discuss how these findings fit into modern fertility evaluation. If you can understand these signs behind endometrial receptivity and uterine blood flow, you are in the right place. So this is how a normal waveform appear like. You can see here non-uterine artery Doppler, uterine artery Doppler. So you can see here, that's the peak systole, that's the diastolic notch that we have there. So I need you to be able to identify the uterine artery like that, and then after that, I need you to be able to measure the resistive index. I'm going to show you how to measure the resistive index and the positivity index. If you know those things now, then we will build it up from there to give feelers and show you how those uterine arteries can be used now to screen for implantation before pregnancy happen. So you must identify the uterine artery there, as you can see there. So if you are able to do this, it means you are in the right direction. So this is one of the things that most people are not able to do, or to identify the uterine artery. So this waveform is very critical. So if you can do a transvaginal nicely. Then you can demonstrate the uterus perfect like that. Everything else will become very easy for you to then assess the uterine artery. So I want you to learn how to, you see where I'm measuring there, that's the uterine artery. There are two, the right and the left. So this is just a demonstration on how to measure one of them. So you should be in a position to do that. When you are able to do that, then the theory that I'm going to teach you now will help you now on how the latest developments that can help us now to screen for fertility before we have other markers happen. Thank you so much. Let's meet in the next presentation, which is now the theory part, where we build everything and you see how it is done, how we assess for infertility or for fertility before everything gets messed up. Thank you so much. Don't forget to subscribe, like, and comment.
Hello, good people. How are you doing? So the case that I have today will shock you. It's one of those things that are very rare. So I need you to watch until the end of this video, and you can see the shocking findings. I hope and I wish that this will shock you as I was shocked also, because it's my first time, and I hope most of you it's also will be your first time to see this type of a pathology. So the first thing that is a transvaginal ultrasound. So you can see here there's a fibroid. This is not the shocking thing. So this is a nice subserosal fibroid there. This is the subserosal fibroid there. You can see this peripheral vascularity. That's our uterus there. You can see the blood vessels there. That's the bladder there is fine. So the fibroid is here. That's a well outlined fibroid there. Well outlined fibroid there. Well outlined fibroid there. So you can see this one microvascular flow. There you can see so there's no color flow inside. You can see the cervix here nicely. The cervix here nicely. There is the thing that I'm talking about. You can see this is a vaginal mass. So there's got the honeycomb structure. You can see this. So what do you think this is, guys? This one, this lesion there. What is this? That's just adjacent to the vagina there, on the vagina wall. There we have it. You can see it has got cystic components. It has got cystic areas like that. What do you think this thing is? What is this? So let's do it together. This mass with the honeycomb structure, mixed solid, and cystic portions like that. What is that? What is that? What do you think that thing is? What is that? So I need you to brainstorm on it. Me, I'm still shocked. I am very much shocked what that thing is. But let me say, my thinking in this case, I am thinking of a high density cyst. So a vaginal high density is very rare, but the morphology of that mass now, it has got the morphology of an echinococcus cyst, high density cyst, the side structure that you've seen there. So you can see here, that's my thinking, my line of thinking, that this is a vaginal echinococcus cyst, but it's a very rare finding, if not one of its own, if not one of its own. So I hope you are also giving you differentials. If you think otherwise, I need you please to send your results on the comment section to say that I think this is what this thing could be. What do you think that is? What do you think that is? Mostly these identity cysts, they do happen inside the liver. That's the most common site for echinococcosis or echinococcal cyst. But in this case now, it's my first time to see a high density cyst that is manifesting itself in the vagina. So the referring clinician was saying that there is a mass in the urethral mass,
but it is not in the urethra on ultrasound, as you have seen. So give me your suggestions. I also need a pool of differentials. What can this be? What can that be? What can that be? What can that be? Initially, I thought it is bowel, but there's no bowel motion, as you can see. The fluid is the only one that is moving a bit. So, what's your take on this, Mas? What's your take? What's your take? So, let's talk, guys. Let's discuss. I need also your assistance. I might be wrong, but my thinking is that this is an echinococcal cyst, a vaginal high-density cyst. So, it's a very rare manifestation. So, I think I'm one of those blessed to have witnessed it during my time of practice. So I just saw it today, just now. So I decided to upload this video because it's one of those most interesting cases. So, but I need your take. I can't be alone in this race, guys. Don't leave me alone. Let's go together. Let's fail together. Let's fail together. Yeah, this was a straightforward diagnosis. Yeah, this was a straightforward diagnosis. Do you know what? Yesterday I did the same patient, a transabdominal sonar. I just reported on the serosal fibroid, but I couldn't pick this one from a trans. So now the mass is presenting low. The doctor sent the patient back. So now we are seeing this one. You see, it's more here. It's more here. So what's your take? What's your take? What's your take? What's your take? Help me, guys. I am also stuck. I am also stuck. But there's no flow, there's some internal or Rolex formation, there's some movement there. And this is the kinetic energy from the probes, that these particles are now moving inside this, but they are not blood vessels. So let's do it together under the comment section. Give me your thoughts. Thank you so much. Don't forget to subscribe and share. Also give your comments and let's talk.
Hello, everyone. So, most of my male clients or patients, they think or they feel that ultrasound is only meant for pregnant scanning. So they get the surprise of their lifetime when they are referred for an ultrasound scan. So now, let me introduce to you medical ultrasound. Even those who are already practicing, the applications of medical ultrasound. This looks like a very simple, straightforward topic, but it's not. Because this is now the foundation of what we are supposed to do. It's the syllabus of medical ultrasound. So what we are going to discuss now, I need you to pay very particular attention to our syllabus of ultrasound. So beyond pregnancy, the diverse application of ultrasound in modern medicine. This is my presentation today. So ultrasound is more than just looking at babies. Did you know that? Yes, you do, because you're a sonographer. Yes, you do, because you're a radiologist. But there's somebody who doesn't know that, the patient, and someone who's being introduced to ultrasound for the first time. We've got students. So, the narration. When many people hear the word ultrasound, they immediately think about pregnancy. While fetal imaging is one of the most recognized uses of ultrasound, these incredible technologies become an indispensable tool across almost every field of medicine. So today, we will explore how ultrasound saves lives, improves diagnosis, guides procedures, and helps doctors make rapid decisions all without radiation. So, what is ultrasound? So by definition, ultrasound is an imaging technique that uses high-frequency sound waves, real-time imaging, no ionizing radiation, and portable technology. So the advantages of ultrasound are it is safe, it's non-invasive, it's affordable to most, it's repeatable, it's real time, and then we can have what is called bedside imaging. So the narration, unlike X-rays or CT scans, ultrasound uses sound waves rather than radiation, making it extremely safe even for repeated examinations. So the obstetric and the pregnancy application, most common application of medical ultrasound: confirm pregnancy, determine gestational age, detect ectopic pregnancy, multiple pregnancies, fetal anomalies, placenta localization, growth monitoring, Doppler assessment, and amniotic fluid assessment. So narration. Although pregnancy imaging remains the most familiar use of ultrasound, it represents only one part of this technology's capabilities. So let's delve more into that. Gynecological application. So ultrasound evaluates fibroids, ovarian cysts, endometriosis, PCOS, pelvic pain, infertility, endometrial pathology, early pregnancy complications, for instance. So the abdominal application of medical ultrasound. Common organs examined: the liver, the gallbladder, the pancreas, the kidneys, the spleen, the abdominal aorta. So the common diagnosis: the fatty liver, the cirrhosis, the gallstones, the kidney stones, hydronephrosis, abdominal aneurysms. So cardiology or echocardiography application of medical ultrasound. It evaluates the heart chambers, the heart valves, ejection fraction, congenital heart disease, pericardial effusions, and cardiomyopathies. So the narration: echocardiograph allows cardiologists to observe the heart beating in real time. So the vascular application of medical ultrasound. Applications: deep venous thrombosis, the varicose veins, carotid stenosis, peripheral artery disease, dialysis fistula assessment, venous insufficiency. So the breast application of ultrasound is used for breast lumps, the cyst, the fibroadenomas, breast cancer evaluation, axillary lymph nodes, ultrasound guided biopsies. So the thyroid applications of medical ultrasound. It detects the thyroid nodules, the goiter, thyroid cancer, enlarged lymph nodes, salivary gland disease. So the musculoskeletal ultrasound application of medical ultrasound, it evaluates the tendons, the ligaments, the muscles, the bursa, the joint effusions, the sports injuries, common conditions, the rotator cuff tears, the Achilles tendon rupture, tennis elbow, plantar fasciitis, for instance. So we also would what is called the emergency ultrasound, which is called the point of care ultrasound, POCUS. So used in emergencies, fast examinations, detects internal bleeding, cardiac tamponade, the pneumothorax, pleural effusion, shock evaluation. So the narration: point of care ultrasound is revolutionized emergency medicine by providing immediate diagnostic information at the bedside. So now, the pediatric ultrasound. Do you know the pediatric application of ultrasound? Applications: infant hips, pyloric stenosis, appendicitis, the kidneys, the neonatal brain, injury susception, to name but a few. So also we got the interventional ultrasound. Interventional ultrasound. Have you ever heard about it? So what is it? It guides needle biopsies, fluid drainages, joint injections, vascular access, nerve blocks, tumor ablation. The benefits of interventional ultrasound are high accuracy, safer procedures, and fewer complications. So now, there is also the imaging applications of medical ultrasound. What are those? So the future directions: AI-assisted ultrasound, elastography, contrast-enhanced ultrasound, handheld ultrasound devices, tele-ultrasound, robotic ultrasound systems. So the narration: artificial intelligence and portable devices are making ultrasound faster, smarter, and more accessible, bridging high-quality imaging to remote and deserved communities. So we are bringing medical ultrasound that is accessible to remote and undeserved communities. So the underserved, undeserved communities. That's where we are taking ultrasound to, using these imaging technologies and applications. So now, why ultrasound matters? The key advantages: one, no radiation, is affordable, it's portable, bedside imaging, dynamic imaging, also with immediate diagnosis, safe for all ages, and cost effective. It also guides treatment. So now, in conclusion, your take home message for the day: ultrasound is not just for pregnancy, it has transformed the diagnosis and management of disease involving their heart, blood vessels, the abdomen, the breast, the thyroid, the muscles, the joints, imaging medicine, pediatrics, image guiding procedures. So the narration: from the imaging room, from the emergency room to the operating theater, from newborn babies to elderly patients, ultrasound continues to transform modern medicine. As technology advances, its role will always continue to expand, making healthcare safer, faster, and more accessible around the world. So, thank you for watching. Like this video, share your favorite ultrasound application in the comments, subscribe to Medical Ultrasound Academy for ultrasound case studies, RDMS and SPI preparations, report writing tutorials, OBS and GYN imaging, Doppler ultrasound, quiz questions, practical scanning tips. So the question of the day that I want to leave you with: which ultrasound specialty interests you the most? Obstetrics, cardiology, vascular, emergency, musculoskeletal, interventional? Let us know in the comments. So we need to compile the preferences, which areas that you should we tackle first, according to the majority wish. Yeah, then we can do the other ones later, because I'm going to teach you all. So to me, this is an introduction. So the areas that I have covered in these presentations are what I am going to teach you or assist you with. So if you got certain areas, so depending on the number, the cumulative number of people who want certain areas, if you say that you want musculoskeletal, we want obstetrics, gynecology, I will center myself much on those areas. So I will focus more on those areas. Then the other ones later, or if there's a 50-50, then I can just be doing them concurrently as we go. Thank you so much for your time. Enjoy the rest of your day. Let's meet again in the next presentation. Bye. Hello, good people. How are you doing? So today we are going to talk about cesarean ectopic pregnancies. So you know, nowadays, because of the prevalence of cesarean sections, so the number or the incidence of ectopic pregnancy is also on the rise. So the high stakes diagnostic challenge in the first trimester ultrasound scan is missing a cesarean scar ectopic pregnancy in the first trimester. That can have devastating consequences for your patient. So I think nobody wants to miss that in an ideal setup or from the professional perspective or standpoint. So do you know exactly what to do or to look for when you're doing an ultrasound scan to make this critical call? So in this guide, we break down the precise scanning protocols and landmarks you need to master before you can say that you're competent in the screening for cervical ectopic pregnancies. Some of you are already competent. I wouldn't take the credit out of you, but educational purposes, you know, some of you, they are not yet competent, and also refreshing and adding pieces of knowledge is always critical and vital. So the expert tutorial style: scanning for cesarean scar pregnancy requires more than just basic ultrasound skills. It demands a specialized eye for detail. we are diving deep into a practical step-by-step walkthrough of documenting these complex cases with clinical accuracy. Learn the essential measurements and imaging planes that ensure an airtight diagnostic report. You know, when I talk about an airtight diagnostic report, we are saying a win-win situation, a don't miss situation where we have to make sure. So now, the visual red flag alert is that a low-lying gestational age or a life-threatening implantation in a previous cesarean scare. So a low-lying gestational sac, if it is low-lying in a previous surgical scare. So distinguishing between these two can be very difficult during early first trimester scans. I'm showing you the red flag visual indicators and documenting techniques every sonographer and clinician must use to identify a cesarean section, ectopic pregnancy before it's too late. So now, what are our learning objectives? What is it that we intend to understand or to master in this lecture? By the end of this presentation, participants should be able to understand the pathology of cesarean scar pregnancy and identify the risk factors. Then you have to recognize the ultrasound diagnostic criteria. Then you must differentiate CSP from cervical pregnancy and miscarriages. So you should perform a systematic ultrasound examination plus produce a comprehensive ultrasound report and identifying possible complications. So understanding current management options can also be very, very critical, because if you see that, you can easily maybe communicate with the relevant authorities or the people in charge. So now, the introduction. A cesarean scare pregnancy is a rare form of ectopic pregnancy where implantation occurs within the fibrous scar of a previous cesarean section. So it is one of the most dangerous ectopic pregnancies because it may lead to massive hemorrhage, uterine rupture, placenta accreta spectrum, maternal death, and emergency hysterectomy. So you can see how devastating it can be, a cesarean scar ectopic pregnancy. So if you have got your uterus there, then the scar is here, then along the line of the scar, that's where you can find that the ectopic pregnancy will be seated there, it will be seated there. At times it can be very difficult to see because the scar is done on the lower segment of the uterus there. It can be very difficult for you, and you can always mistake it for an aborting cyst, which is the cyst that happens within your cervix. So now, why early diagnosis matters? Why does early diagnosis matter in the first instance? Diagnosis before 8 weeks significantly reduces complications. If diagnosis is done late, placenta invades deeply, the myometra becomes thinner, the risk of rupture increases, and surgical management becomes very, very difficult. So in the end, hysterectomy will be done. So what is the epidemiology? What is the epidemiology? Approximately 1 in 1,800 to 2,500 pregnancies after cesarean delivery. So around 6% of ectopic pregnancy in women with previous cesarean delivery. So increasing incidence due to rising cesarean section rates and improved early ultrasound. So now, the risk factors. What are some of the risk factors for a cesarean ectopic pregnancy? So previous cesarean section, most important, multiple cesarean deliveries, myomectomy, manual placenta removal, dilation and curettage, IVF pregnancy, uterine surgery, thin lower uterine segment. So what is the pathophysiology of this type of an ectopic pregnancy? Instead of implanting inside the normal endometrium, the embryo implants into the microscopic tracts within the cesarean scar. The trophoblast invades directly into the
fibrous scar tissue in the myometrium, a highly vascular tissue. So this explains why severe bleeding and placenta accreta and early uterine rupture normally precede. So now the types of CSP. Type 1, which is called the endogenic type. Pregnancy grows towards the endometrial cavity and it has got a better prognosis. So the type 2, which is the most dangerous, which is the exogenic one. Pregnancy grows towards the bladder, the abdominal cavity, and it was a higher risk of rupture. So now the clinical presentation. Many patients are asymptomatic. Symptoms include vaginal bleeding, low abdominal pain, positive pregnancy tests, sometimes discovered incidentally. So the ultrasound equipment for diagnosis of a scar ectopic pregnancy is best is transvaginal. Use high frequency probe, color Doppler, power Doppler if available, 3D ultrasound when available. So now, the examination technique now. Step 1, you should evaluate the uterine cavity. Step 2, evaluate the cervix. Step 3, you should evaluate the lower uterine segment. Then step 4, locate gestational sac. Step 5, you should measure the myometrial thickness. In step 6, you should apply color Doppler. So now the diagnostic criteria, the uterine cavity is empty. The cervical canal is empty. The gestational sac is embedded in the anterior lower uterine segment. Sac lies exactly at the cesarean scar. Thin or absent myometrium, usually less than 5 millimeters, sometimes 1 to 2 millimeters. Rich peritrophoblastic blood flow. Color Doppler demonstrates high velocity, low resistance vascularity. So now, the sliding organ sign, one of the most useful signs. If you remember when we were discussing about endometriosis, we spoke about the sliding sign. So one of the most useful signs, using gentle probable pressure, miscarriage, sac slides, cesarean scar, pregnancy, sac remains fixed. So when there is an ectopic cesarean scar pregnancy, the sac is fixed, it doesn't slide. But when you have got a normal, when you have got a normal or pregnancy or a miscarriage, then the sac should be sliding. So the color Doppler findings. So here you can see what we have there. We can see what we have there, the scar pregnant, the scar ectopic pregnant there, where it is there. So you should look for the hypervascular ring, the low resistant flow, the feeding vessels, the increased vascularity at the scar. You should check the increased vascularity at the scar. So you must pay due diligence to that. So the myometrial thickness, measure between the gestational sac, the serosal surface, the normal 5 millimeters, suspicious if it's less than 5 millimeters, it's critical when it's less than 2 millimeters. So the relationship to the bladder, important because the thin myometrium increases the bladder invasion risk. Always document distance between sac and the bladder. The embryo assessment, document the gestational sac size, the yolk sac, the fetal pole, the crown rumble length, and the cardiac activity. So the measurements to include measure mean sac diameter, the crown rumble length, the myometrial thickness, sac distance from the internal os, the scar niche dimensions if visible. So most of the time the niche will not be visible. So the differential diagnosis that you can get, don't just always rush to say that it's a cesarean scar ectopic pregnancy. It might not be. It might also be endometriosis. It could be adenomyosis. It could be cyst. So it could be niche as well without anything. So differential diagnosis condition, cesarean, scar, ectopic pregnancy, the uterine cavity is empty, the cervix is empty, the sliding sign is negative, then the scar location, yes. Cervical pregnancy, the uterine cavity is empty, the cervix is occupied, then the sliding sign is negative. So the scar location, no. For miscarriage, the uterine cavity is variable, cervix, sac is in the canal. For miscarriage, you can find the sac in the canal before if it is expelled, or it can be expelled. You can see a normal canal. So the sliding sign is positive with the miscarriage. The scar location, there's no scar location. So the low implantation occupied within the uterine cavity, the cervix is empty, the sliding sign is variable, then the scar location, no, it's not within the scar itself. So cervical ectopic pregnancy versus cesarean scar ectopic pregnancy, those are some of the things that can be confusing. So the cesarean scar ectopic pregnancy, sac implanted anteriorly, scar defect visible, thin myometrium with a rich vascularity, whereas a cervical pregnancy, sac inside the cervical canal, intact arterial myometrium with a different blood supply. So now, this is the reporting checklist. When you are doing the report now, every report should include the patient history, the previous cesarean section, previous gestation, the gestational age, sorry, sac location, the embryo present, is it present or absent, then heartbeat present, absent, color Doppler findings, the myometrial thickness, distance to the bladder, then presence of free fluid, the adnexia, the ovaries, then the final impression. So here's a simple summary report that you can use as a template, or you can devise your own, it's fine, as long as capturing everything that is needed. So you supply the clinical history, 7 weeks amenorrhea with the previous lower segment cesarean section. So the findings, you can document empty uterine cavity, empty cervical canal, gestational sac implanted within the anterior lower uterine segment at the site of the previous cesarean section, live embryo demonstrated with the current rumble length corresponding to 7 weeks and 2 days, cardiac activity is present, residual anterior myometrium measures 2.1 millimeters, marked peri-trophoblastic vascularity, demonstrated on color Doppler. So no free fluid noted in the POD, both ovaries appear normal. So the impression, live cesarean section scar ectopic pregnancy with marked vascularity and markedly thinned residual myometrium, urgent obstetric or gynecologic consultation is recommended. So potential complications of a cesarean ectopic pregnancy, complications include uterine rupture, massive hemorrhage, placenta accreta, spectrum, bladder invasion, hysterectomy, and maternal death. So management overview. Treatment depends on gestational age, fetal cardiac activity, myometrial thickness, hemodynamic instability, future fertility wishes. Options may include medical management, e.g., methotrexate in selected cases, ultrasound guided interventions, hysteroscopic and laparoscopic or open surgical incision are recommended. Uterine artery embolization is an adjunct in selected patients. So management should be individualized and coordinated with an experienced obstetric or gynecological team member. So the common mistakes some of you do, or that we do, including myself, is avoid calling it a low intrauterine pregnancy, avoid calling it a low intrauterine pregnancy, ignoring the cesarean scar history, omitting myometrial thickness, and not using color Doppler, failing to assess bladder proximity, missing fetal cardiac activity, and omitting urgent recommendations. So those are some of the pitfalls
So the key cues in this presentation: always suspect a cesarean scar, ectopic pregnancy in the first trimester when there is a history of cesarean delivery and a low anterior gestational sac. So transvaginal ultrasound with color Doppler is the imaging modality of choice. Confirm the combination of empty uterine cavity, empty cervical canal, scar implantation, thin residual mementum, and prominent peritrophoblastic vascularity. Measure and report residual memental thickness and the relationship of the pregnancy to the bladder. Early diagnosis is critical to reduce the risk of uterine rupture, severe hemorrhage, and loss of fertility. So, ladies and gentlemen, this brings us to the end of our today's presentation. I hope that you've benefited, a useful thread. So these are the building blocks, the pillars of medical ultrasound. That's how it is done. You know, we do it step at a time. Thank you so much. Enjoy the rest of your day. Don't forget to subscribe to our channel and also share the educational content with your colleagues. Enjoy the rest of your day. Let's meet again in the next presentation. Bye. Hello, good people. How are you doing? So today we are going to talk about cesarean ectopic pregnancies. So you know, nowadays, because of the prevalence of cesarean sections, so the number or the incidence of ectopic pregnancy is also on the rise. So the high stakes diagnostic challenge in the first trimester ultrasound scan is missing a cesarean scar ectopic pregnancy in the first trimester. That can have a devastating consequences for your patient. So I think nobody wants to miss that in an ideal setup or from the professional perspective or standpoint. So do you know exactly what to do or to look for when you're doing an ultrasound scan to make this critical call? So in this guide, we break down the precise scanning protocols and landmarks you need to master before you can say that you're competent in the screening for cervical ectopic pregnancies. Some of you are already competent. I wouldn't take the credit out of you, but educational purposes, you know, some of you, they are not yet competent, and also refreshing and adding pieces of knowledge is always critical and vital. So the expert tutorial star, scanning for a scar pregnancy requires more than just basic ultrasound skills. It demands a specialized eye for detail. We are diving deep into a practical step-by-step walkthrough of documenting these complex cases with clinical accuracy. Learn the essential measurements and imaging planes that ensure an airtight diagnostic report. You know, when I talk about an airtight diagnostic report, we are saying a win-win situation, a don't miss situation where we have to make sure. So now, the visual red flag alert is that a low-lying gestational age or a life-threatening implantation in a previous cesarean scale. So a low-lying gestational sac, if it is low-lying in a previous surgical scale. So distinguishing between these two can be very difficult during early first trimester scans. I'm showing you the red flag visual indicators and documenting techniques every sonographer and clinician must use to identify a cesarean section, ectopic pregnancy before it's too late. So now, what are our learning objectives? What is it that we intend to understand or to master in this lecture? By the end of this presentation, participants should be able to understand the pathology of cesarean scar pregnancy and identify the risk factors. Then you have to recognize the ultrasound diagnostic criteria. Then you must differentiate CSP from cervical pregnancy and miscarriages. So you should perform a systematic ultrasound examination plus produce a comprehensive ultrasound report and identifying possible complications. So understanding current management options can also be very, very critical, because if you see that, you can easily maybe communicate with the relevant authorities or the people in charge. So now, the introduction. A cesarean scare pregnancy is a rare form of ectopic pregnancy where implantation occurs within the fibrous scar of a previous cesarean section. So it is one of the most dangerous ectopic pregnancies because it may lead to massive hemorrhage, uterine rupture, placenta accreta spectrum, maternal death, and emergency hysterectomy. So you can see how devastating it can be, a cesarean scar ectopic pregnancy. So if you have got your uterus there, then the scar is here, then along the line of the scar, that's where you can find the ectopic pregnancy will be seated there, it will be seated there. At times it can be very difficult to see because the scar is done on the lower segment of the uterus there. It can be very difficult for you, and you can always mistake it for an aborted cyst, which is the cyst that happens within your cervix. So now, why early diagnosis matters? Why does early diagnosis matter in the first instance? Diagnosis before 8 weeks significantly reduces complications. If diagnosis is done late, placenta invades deeply, the myometra becomes thinner, the risk of rupture increases, and surgical management becomes very, very difficult. So in the end, hysterectomy will be done. So what is the epidemiology? What is the epidemiology? Approximately 1 in 1,800 to 2,500 pregnancies after cesarean delivery. So around 6% of ectopic pregnancy in women with previous cesarean delivery. So increasing incidence due to rising cesarean section rates and improved early ultrasound. So now, the risk factors. What are some of the risk factors for a cesarean ectopic pregnancy? So previous cesarean section, most important, multiple cesarean deliveries, myomectomy, manual placenta removal, dilation and curettage, IVF pregnancy, uterine surgery, thin lower uterine segment. So what is the pathophysiology of this type of an ectopic pregnancy? Instead of implanting inside the normal endometrium, the embryo implants into the microscopic tracts within the cesarean scar. The trophoblast invades directly into the fibrous scar tissue in the myometrium, a highly vascular tissue. So this explains why severe bleeding and placenta accreta and early uterine rupture normally precede. So now the types of CSP. Type 1, which is called the endogenic type. Pregnancy grows towards the endometrial cavity and it has got a better prognosis. So the type 2, which is the most dangerous, which is the exogenic one. Pregnancy grows towards the bladder, the abdominal cavity, and it has a higher risk of rupture. So now the clinical presentation. Many patients are asymptomatic. Symptoms include vaginal bleeding, lower abdominal pain, positive pregnancy tests, sometimes discovered incidentally. So the ultrasound equipment for diagnosis of a scar ectopic pregnancy is best is transvaginal. Use high frequency probe, color Doppler, power Doppler if available, 3D ultrasound when available. So now, the examination technique now. Step 1, you should evaluate the uterine cavity. Step 2, evaluate the cervix. Step 3, you should evaluate the lower uterine segment. Then step 4, locate gestational sac. Step 5, you should measure the myometrial thickness. And step 6, you should apply color Doppler. So now the diagnostic criteria, the uterine cavity is empty, the cervical canal is empty, the gestational sac is embedded in the anterior lower uterine segment, sac lies exactly in the cesarean scar. Thin or absent myometrium,
usually less than 5 millimeters, sometimes 1 to 2 millimeters. Rich peritrophoblastic blood flow. Color Doppler demonstrates high velocity, low resistance vascularity. So now, the sliding organ sign, one of the most useful signs. If you remember when we were discussing about endometriosis, we spoke about the sliding sign. So one of the most useful signs, using gentle probable pressure, miscarriage, sex slides, cesarean scar, pregnancy, sex remains fixed. So when there is an ectopic cesarean scar pregnancy, the sac is fixed, it doesn't slide. But when you have got a normal, when you have got a normal or pregnancy or a miscarriage, then the sac should be sliding. So the color Doppler findings. So here you can see what we have there. We can see what we have there, the scar pregnant, the scar ectopic pregnant there, where it is there. So you should look for the hypervascular ring, the low resistant flow, the feeding vessels, the increased vascularity at the scar. You should check the increased vascularity at the scar. So you must pay due diligence to that. So the myometrial thickness, measure between the gestational sac, the serosal surface, the normal 5 millimeters, suspicious if it's less than 5 millimeters, it's critical when it's less than 2 millimeters. So the relationship to the bladder, important because the thin myometrium increases the bladder invasion risk. Always document distance between sac and the bladder. The embryo assessment, document the gestational sac size, the yolk sac, the fetal pole, the crown rumble length, and the cardiac activity. So the measurements to include measure mean sac diameter, the crown rumble length, the myometrial thickness, sac distance from the internal os, the scar niche dimensions if visible. So most of the time the niche will not be visible. So the differential diagnosis that you can get, don't just always rush to say that it's a cesarean scar ectopic pregnancy. It might not be. It might also be endometriosis. It could be adenomyosis. It could be cyst. So it could be niche as well without anything. So differential diagnosis condition, cesarean scar ectopic pregnancy, the uterine cavity is empty, the cervix is empty, the sliding sign is negative, then the scar location, yes. Cervical pregnancy is the uterine cavity is empty, the cervix is occupied, then the sliding sign is negative. So the scar location, no. For miscarriage, the uterine cavity is variable, cervix, sac is in the canal. For miscarriage, you can find the sac in the canal before if it is expelled, or it can be expelled. You can see a normal canal. So the sliding sign is positive with the miscarriage. The scar location, there's no scar location. So the low implantation occupied within the uterine cavity, the cervix is empty, the sliding sign is variable. Then the scar location, no, it's not within the scar itself. So cervical ectopic pregnancy versus cesarean scar ectopic pregnancy, those are some of the things that can be confusing. So the cesarean scar ectopic pregnancy, sac implanted anteriorly, scar defect visible, thin myometrium with a rich vascularity, whereas a cervical pregnancy, sac inside the cervical canal, intact arterial myometrium with a different blood supply. So now, this is the reporting checklist. When you are doing the report now, every report should include the patient history, the previous cesarean section, previous the gestational age, sac location, the embryo present, is it present or absent? Then heartbeat, present, absent. Color Doppler findings, the myometrial thickness, distance to the bladder, then presence of free fluid, the adnexia, the ovaries, then the final impression. So here's a simple summary report that you can use as a template, or you can devise your own. It's fine, as long as capturing everything that is needed. So you supply the clinical history, 7 weeks amenorrhea with the previous lower segment cesarean section. So the findings, you can document empty uterine cavity, empty cervical canal, gestational sac implanted within the anterior lower uterine segment at the site of the previous cesarean section. Live embryo demonstrated with the current rumble length corresponding to 7 weeks and 2 days. Cardiac activity is present. Residual anterior myometrial measures 2.1 millimeters, marked peritrophoblastic vascularity, demonstrated on color Doppler. So no free fluid noted in the POD. Both ovaries appear normal. So the impression: live cesarean section scar, ectopic pregnancy with marked vascularity and markedly thinned residual myometrium. Urgent obstetric or gynecologic consultation is recommended. So potential complications of a cesarean ectopic pregnancy. Complications include uterine rupture, massive hemorrhage, placenta accreta spectrum, bladder invasion, hysterectomy, and maternal death. So management overview. Treatment depends on gestational age, fetal cardiac activity, myometrial thickness, hemodynamic instability, future fertility wishes. Options may include medical management, e.g., methotrexate in selected cases, ultrasound guided interventions, hysteroscopic and laparoscopic or open surgical incision are recommended. Uterine artery embolization is an adjunct in selected patients. So management should be individualized and coordinated with an experienced obstetric or gynecological team member. So the common mistakes some of you do, or that we do, including myself, is avoid calling it a low intrauterine pregnancy, avoid calling it a low intrauterine pregnancy, ignoring the cesarean scar history, omitting myometrial thickness, not using color Doppler, failing to assess bladder proximity, missing fetal cardiac activity, and omitting urgent recommendations. So those are some of the pitfalls. So the key cues in this presentation: always suspect a cesarean scar, ectopic pregnancy in the first trimester when there is a history of cesarean delivery and a low anterior gestational sac. So transvaginal ultrasound with color Doppler is the imaging modality of choice. Confirm the combination of empty uterine cavity, empty cervical canal, scar implantation, thin residual myometrium, and prominent peritrophoblastic vascularity. Measure and report residual myometrial thickness and the relationship of the pregnancy to the bladder. Early diagnosis is critical to reduce the risk of uterine rupture, severe hemorrhage, and loss of fertility. So, ladies and gentlemen, this brings us to the end of our today's presentation. I hope that you've benefited, a useful thread. So these are the building blocks, the pillars of medical ultrasound. That's how it is done. You know, we do it step at a time. Thank you so much. Enjoy the rest of your day. Don't forget to subscribe to our channel and also share the educational content with your colleagues. Enjoy the rest of your day. Let's meet again in the next presentation. Bye.
Hello colleagues, how are you? Now we are going to do the cesarean scar pregnancy quiz. These are detailed ultrasound quiz questions. They are just 6 questions that I need us to attempt. So question number 1, where is the gestational sac? Where is the gestational sac? Where is the gestational sac? You can see there. Where is this? Clinical scenario: a 32-year-old woman, G3P2 with 2 previous cesarean sections, presents at 7 weeks gestation with light vaginal bleeding. Transvaginal ultrasound demonstrate empty uterine cavity, empty cervical canal, gestational sac located in the anterior lower uterine segment, sac impeded in the previous cesarean scar. Which is the most likely diagnosis? A. Cervical ectopic pregnancy. B. Incomplete miscarriage. C. Cesarean scar pregnancy. D. Low intrauterine pregnancy. So these quiz questions are just meant for or revision to enhance on what we have done in the lecture. So it's not an examination, but just an enhancement lecture so that you master what we have just done. So which is the correct answer? Which one is the correct answer? Transvaginal ultrasound demonstrate empty uterine cavity, empty cervical canal, gestational sac located in the anterior lower uterine segment. Sac immediately the previous cesarean scar. Which is the most likely diagnosis? A. Cervical pregnancy. B. Incomplete miscarriage. C. Cesarean scar pregnancy. D. Lower uterine pregnancy. So the answer is C, which is cesarean scar pregnancy. The explanation: the combination of empty uterine cavity, empty cervical canal, gestational sac implanted within the anterior lower uterine segment at the cesarean scar is diagnostic of a cesarean scar pregnancy. So let's proceed. Question number 2. Which ultrasound finding confirms the diagnosis? So you see there, you see there, you see there, you see there. Clinical scenario: a woman with one previous cesarean section is scanned at 6 weeks. Ultrasound shows gestational sac in the lower arterial uterus. Residual millimeter measures 1.8 millimeters. Intense vascularity surrounding the sac, as you can see there. Which finding most strongly suggests cesarean scar pregnancy? A. Thick endometrium. B. Simple ovarian cyst. C. Thin residual endometrium with rich peritrophoblastic blood flow. D. Free pelvic fluid. Which a woman with one previous cesarean scar is scanned at 6 weeks. Ultrasound shows gestational sac in the lower anterior uterus. Residual millimeter measures 1.8 millimeters. Intense vascularity surrounding the sac. Which finding most suggest cesarean scar pregnancy? A. Thick endometrium. B. Simple ovarian cyst. C. Thin residual endometrium with rich peritrophoblastic blood flow. D. Free fluid. So our correct answer here is C. Explanation: typical cesarean ectopic pregnancy demonstrate very thin residual endometrium, hypervascular trophoblastic ring, low resistant Doppler flow. These findings will distinguish CSP from miscarriage or low intrauterine pregnancy. So question number 3, differential diagnosis. Clinical scenario: a patient has empty uterine cavity, gestational sac inside the cervical canal, normal anterior lower uterine wall, no scar implantation. That is what we have there. Differential diagnosis. What is the diagnosis? A. Cesarean scar pregnancy. Cervical ectopic. C. Miscarriage. D. Placenta previa. A clinical scenario: a patient is empty uterine cavity, gestational sac inside the cervical canal, normal anterior lower uterine wall, no scar implantation. What is the good diagnosis? A. Cesarean scar pregnancy. B. Cervical pregnancy. C. Miscarriage. D. Placenta previa. So the correct answer is cervical pregnancy. The explanation: unlike CSP, a cervical pregnancy planted within the cervical canal, not in the anterior lower uterine segment scar. So question number 4, the Doppler interpretation. Clinical scenario: color Doppler demonstrates numerous vessels surrounding the gestational sac, high velocity flow, low resistance waveform. What does that represent? A. Corpus luteum. B. Placenta insufficiency. Active trophoblastic invasion. D. Endometrial polyp. So what does that represent? Color Doppler interpretation. Clinical scenario: color Doppler demonstrate numerous vessels surrounding the gestational sac, high velocity flow, low resistance waveform. What does this represent? A. Corpus luteum. B. Placenta insufficiency. C. Active trophoblastic invasion. D. Endometrial polyp. So the correct answer is C. The intense vascular ring represents active trophoblastic invasion, a hallmark of viable cesarean scar pregnancy.
The intense vascular ring represents active trophoblastic invasion, a hallmark of viable cesarean scar pregnancy. Question number 5, which measurement is most important? Which measurement is most important? There you see there's a niche there, there's a record niche there, then you see there's this ectopic pregnancy there in the cesarean scar. Clinical scenario, while documenting a suspected CSP, which measurement is most critical to include the ultrasound report? A, ovarian volume, B, endometrial thickness, C, residual myometrial thickness between the gestational sac and the bladder, C, cervical length. Clinical scenario, where documented suspect the CSP, which measurement is most critical to include in the ultrasound report? A, ovarian volume, B, endometrial thickness, C, residual myometrial thickness between the gestational sac and the bladder, D, the cervical length. So the correct answer is C, the explanation. Residual myometrial thickness estimate the risk of uterine rupture, placenta accreta spectrum, blood invasion. It is one of the most important measurements in the report. So question number 6, this is the reporting challenge. There we have the scenario that we have the clinical scenario. Your ultrasound findings include empty uterine cavity, empty cervical canal, live embryo in previous cesarean scar, residual myometrium is 2 millimeters, marked peri-trophoblastic vascularity, as you can see there, residual myometrium which is only 2 millimeters, marked peri-trophoblastic vascularity, no free fluid. Which is the best explanation? A, threatened miscarriage, B, low intrauterine pregnancy, C, pregnancy of unknown location. So the and then D, live cesarean scar, ectopic pregnancy, marked thinned residual myometrium. Clinical scenario, your ultrasound findings include empty uterine cavity, empty cervical canal, live embryo the previous cesarean scar, residual myometrium 2 millimeters, marked peri-trophoblastic vascularity, no free fluid. Which is the best interpretation? Threatened miscarriage, low intrauterine pregnancy, pregnancy for unknown location, live cesarean scar, ectopic pregnancy, marked thinned residual myometrium. So the correct answer is D. The impression should clearly identify the pregnancy is a live cesarean scar, ectopic pregnancy, the presence of markedly thinned residual myometrium indicating increased risk, the need for IGN specialist or obstetric gynecological assessment. So the bonus question, true or false, a positive sliding signs suggests the diagnosis of a cesarean scar ectopic pregnancy? A, the answer is false. In a cesarean scar pregnancy, the gestational sac is firmly implanted within the scar and does not slide with gentle pressure from the transvaginal probe. A positive sliding sac sign is more consistent with a miscarriage in progress rather than a cesarean scar pregnancy. So, ladies and gentlemen, this brings us to at the end of our quiz session. So, these quiz sessions are meant for learning. They are not examination questions. So, I hope you are learning a useful trade from them. Take them very seriously. They will assist you with your daily diagnosis as you do your practice or your work. Enjoy the rest of your day. Let's meet again in the next presentation. So I encourage you to comment if you've got areas that you need me to present on or to tackle or to clarify on. I will do that with pleasure. Feel free under the comment section to add your comments. If you would any suggestions, I also take those ones. Thank you so much. Enjoy the day.
Welcome back, colleagues. So, learning without assessing your knowledge is useless. So, in this episode, we are going to tackle some 6 quiz questions. So, these are on identifying subtle fetal cleft lip signatures using the maxillary line technique. These questions are designed for sonographers, radiologists, obstetricians, and other students. Each includes a detailed explanation and recommending image for presentation. So question number 1, A 22-week fetal anomaly scan demonstrated a smooth and uninterrupted echogenic maxillary line on the coronal facial view. A 22-week fetal anomaly scan demonstrated a smooth, uninterrupted echogenic maxillary line on the coronal facial view. The upper lip and nostrils appear symmetrical. What is the most likely diagnosis? A 22-week fetal anomaly scan demonstrates smooth, uninterrupted echogenic maxillary line on the coronal facial view. The upper lip and nostrils appear symmetrical. What is the most likely diagnosis? A. Unilateral cleft lip. B. Bilateral cleft lip. C. Normal fetal upper lip. D. Cleft with a palate. So the correct answer is A. Unilateral cleft lip. B. Bilateral cleft lip. C. Normal fetal upper lip. D. Cleft lip with palate. So the correct answer is normal fetal upper lip. So the explanation: the maxillary line should appear as a continuous bright echogenic line without interruption or asymmetry. A normal coronal facial view demonstrates continuous upper lip, symmetrical nostrils, intact philantrum, smooth alveolar ridge, no defect in the maxillary line. These findings exclude the cleft lip. So a normal coronal facial view demonstrates continuous upper lip, symmetrical nostrils, intact philantrum, smooth alveolar ridge, no defect in the maxillary line. These findings exclude the cleft lip. So the educational appeal: a continuous maxillary line is one of the strongest indicators of normal upper lip. Now let's go to question number 2. During a 20-week anatomy scan, the sonographer noticed a small interruption of the left side of the upper lip. The left nostril is widened and the maxillary line is interrupted on one side only. What is the diagnosis? During a 20-week anatomy scan, the sonographer noticed a small interruption of the left side of the upper lip. The left nostril is widened and the maxillary line is interrupted on one side only. What is the most likely diagnosis? A. Bilateral cleft lip. B. Unilateral cleft lip. C. Normal variation. D. Isolated cleft palate. What is the correct answer? During a 20-week anatomy scan, the sonographer noticed a small interruption of the left side of the upper lip. The left nostril is widened and the maxillary line is interrupted on one side only. What is the diagnosis? A. Bilateral cleft lip. B. Unilateral cleft lip. C. Normal variation. D. Isolated cleft palate. So the correct answer is B, which is the unilateral cleft lip. Explanation: typical ultrasound findings include break in the upper lip, interrupted maxillary line, nostril asymmetry, missing soft tissue on one side, normal opposite side. These findings are classic for unilateral cleft lip. Educational appeal: most cleft lips are unilateral and occur most frequently on the left side. Question number 3. A fetal facial scan shows interruption of the maxillary line on both sides with a protruding central premaxilla. Which diagnosis is most likely? A fetal facial scan shows interruption of the maxillary line on both sides with a protruding central premaxilla. Which diagnosis is most likely? A. Isolated cleft lip. B. Bilateral cleft lip. C. Normal upper lip. D. Facial artifact. A fetal facial scan shows interruption of the maxillary line on both sides with the protruding central premaxilla. Which diagnosis is most likely? A. Isolated cleft lip. B. Bilateral cleft lip. C. Normal upper lip. D. Facial artifact. So the correct answer is B. Bilateral cleft lip. The explanation: characteristic findings include bilateral interruption of the lip, a floating premaxilla, wide facial defect, symmetrical abnormalities, flattened upper lip contour. So the educational appeal: protruding premaxilla is a classic feature of bilateral complete cleft lip. Question number 4. An interrupted upper lip is identified on coronal view imaging. Axial imaging demonstrates a discontinuity of the alveolar ridge extending into the palate. What is the diagnosis? An interrupted upper lip is identified on coronal imaging. Axial imaging demonstrates a discontinuity of the alveolar ridge extending into the palate. What is the correct diagnosis? A. Isolated cleft lip. B. Cleft lip with cleft palate. C. Normal features. D. Facial shadow artifact. An interrupted upper lip is identified on coronal imaging. Axial imaging demonstrates a discontinuity of the alveolar ridge extending to the palate. What is the diagnosis? A. Isolated cleft lip. B. Cleft lip with cleft palate. C. Normal features. D. Facial shadow artifact. So the correct answer is B, which is cleft lip with cleft palate. The explanation: palatal involvement is suggested when lip defects extend posteriorly, alveolar ridge is interrupted, hard palate is discontinuous, oral and nasal cavities communicate. These findings indicate combined cleft lip and palate. So, palatal involvement is suggested when lip defect extends posteriorly, alveolar ridge is interrupted, hard palate is discontinuous, oral and nasal cavities communicate. These findings indicate combined cleft lip and palate. So the educational appeal: always evaluate the palate whenever a cleft lip is detected because associated palatal defects are common. Question number 5. A suspected defect is seen on the fetal upper lip. After waiting for fetal movement, the apparent defect disappears. What is the most likely explanation? A suspected defect is seen on the fetal upper lip. After waiting for fetal movement, the apparent defect disappears. What is the most likely explanation? A true unilateral cleft lip. B. Facial artifact caused by fetal position. C. Bilateral cleft lip. D. Cleft palate. A suspected defect is seen on the fetal upper lip. After waiting for fetal movement, the apparent defect disappears. What is the most likely explanation? A. True unilateral cleft lip. B. Facial artifacts caused by fetal position. C. Bilateral cleft lip. D. Cleft palate. So the correct answer is B. That is facial artifact caused by fetal position. The facial artifact caused by fetal position. Explanation: false positive appearance may result from fetal hand covering the mouth, umbilical cord across the face, acoustic shadowing, poor insonation angle, maternal body habitus. Always reassess in multiple planes after fetal movement. So the educational appeal: never diagnose a cleft lip from a single image. Confirm the finding in sagittal, coronal, axial, and if available 3D views. Question number 6. Which fetal facial abnormality remains the most difficult to diagnose prenatally using ultrasound because the upper lip may appear completely normal? Which fetal facial abnormality remains the most difficult to diagnose prenatally using the ultrasound because the upper lip may appear completely normal? A. Bilateral cleft lip. B. Unilateral cleft lip. C. Isolated palate. D. median cleft lip. Which fetal facial abnormality remains the most difficult to diagnose prenatally during ultrasound because the upper lip may appear completely normal? A. Bilateral cleft lip. B. Unilateral cleft lip. C. Isolated cleft palate, sorry. D. Median cleft lip. So the answer is C, which is isolated cleft lip. The explanation: isolated cleft palate is challenging because the upper lip is intact, the palate is deep within the oral cavity, and difficult to visualize. Acoustic shadowing from facial bones can obscure the defect. Dedicated axial and coronal or palatal views, as well as advanced techniques such as 3D imaging, improve detection but do not identify all cases. So the educational appeal: the maxillary line technique is excellent for detecting cleft lip, but a normal maxillary line does not exclude an isolated cleft palate. A systematic assessment of the palate is essential whenever possible. So, ladies and gentlemen, this marks the end of our quiz session. All the best to those who have attempted these questions. These are not quiz for an examination. These are academic quiz that enhances your knowledge and your understanding of cleft lip and palate diagnosis. Thank you so much. All the best in your practices. Don't forget to subscribe, share, and comment our educational content. Thank you.
Hello and welcome. So today let's talk about improving diagnosis accuracy by correlating ultrasound findings with patient clinical history. So this is a practical guide for every sonographer and ultrasound practitioner. Our introduction. So improving diagnosis accuracy by correlating ultrasound findings with the patient clinical history. So the key message: ultrasound should never be interpreted in isolation. The patient history often determines whether an ultrasound finding is normal, abnormal, or incidental, or life-threatening. So the objectives of this presentation: by the end of this presentation, participants should be able to appreciate the importance of clinical history, recognize history that changes ultrasound interpretation, improve diagnostic confidence, and avoid common diagnostic pitfalls, produce clinically useful reports, and communicate effectively with referring clinicians. So why clinical history matters? Why does it matter in the first place? Why should we bother ourselves when doing ultrasound? Why should we bother ourselves with clinical history? Ultrasound is highly operator dependent. The image alone does not provide the diagnosis. The diagnosis is reached by combining the clinical symptoms, the medical history, the physical examination, laboratory results, and the ultrasound findings. So the formula that we use is clinical history plus ultrasound plus laboratory findings is equal to better diagnosis. So this is an equation. This is a formula that you must master. Clinical history plus ultrasound plus laboratory findings is equivalent to the final diagnosis. So now, the three pillars of diagnosis, what are they? Patient, the history, ultrasound, clinical correlation, and then the final diagnosis. A beautiful scan interpreted without history may still lead us to a wrong diagnosis. Even if you have got a very beautiful ultrasound scan interpreted without history, it might lead us to a misdiagnosis. So the patient, the history, the ultrasound, clinical correlation, and then the final diagnosis followed. So what clinical information should every sonographer collect? The general information: the age of the patient, the sex of the patient, the occupation of the patient, the weight of the patient, the height of the patient. These influence expected pathology, disease prevalence, technical scanning difficulty. Example: a 19-year-old with pelvic pain
is a very different differential diagnosis from a 72-year-old with the same pelvic pain. Get that right. So, presenting complaint, always ask what brings you here today. Examples: pain, bleeding, swelling, lump, infertility, amenorrhea, the trauma, fever. Never rely on the request form. Never, never, never. Patients often reveal important additional information when you're doing the sonar. Pain history. Ask where did it start, constant or intermittent, the severity of the pain, radiation, relation to meals, relation to menstruation, relation to pregnancy, pain location, direct your scan. So example, right upper quadrant pain, possible diagnosis, gallstones, acute cholecystitis, liver abscess, hepatitis, kidney pathology. The same liver lesion means different things depending on symptoms. The same liver lesion means different things depending on the symptoms. So, the previous medical history, always ask about diabetes, hypertension, cancer, liver disease, kidney disease, thyroid disease, HIV, tuberculosis. Past disease often predicts current findings. So, the previous surgery, critical questions: previous cesarean section, hysterectomy, cholecystectomy, appendectomy, myomectomy, thyroid surgery. So initially, I was very stupid. I wrote a report where I was saying that the gallbladder was very normal. You know, when you're using the reports, the templates don't edit. Yet the patient had a cholecystectomy 3 years back. It was very embarrassing of me. So you must always ask the history of all those previous surgical history, if all those organs are there or they were removed. Otherwise, you embarrass yourself to say that the uterus is normal when a hysterectomy was done or cholecystectomy was done. Example, scale endometriosis is possible to suspect without history. Scale endo is impossible to suspect without surgical history. You understand this? So it is very difficult for you to think of scale endometriosis if you don't have the history. So obstetric history, for a pregnant patient, ask the LMP, gravidity, the parent, previous miscarriage, previous ectopic pregnancy, IVF pregnancy, previous cesarean section. These dramatically influence interpretation. So the example, positive pregnancy test, ultrasound, no intrauterine pregnancy, without history, pregnancy of unknown location with the previous ectopic pregnancy, very high suspicion for recurrent ectopic. So the menstrual history, you must always document the LMP, cycle length, regularity, menopause. These changes endometrial interpretation. Example, endometrial measuring 12 millimeters, normal in secretory phase, abnormal in post-menopausal bleeding. So the medication history, important medications like tamoxifen, oral contraceptives, hormone replacement therapy, anticoagulants, fertility drugs. These explain many ultrasound findings. So the laboratory correlation, combine ultrasound with beta HCG, PSA, liver function test, CRP, WBC, creatinine, AFP, CA125. Ultrasound alone rarely provides the full picture. So now, the clinical correlation obstetrics, history determines interpretation. Example, positive pregnancy test, pain,
raise suspicion for miscarriage, ectopic pregnancy, molar pregnancy. So if someone comes with pain, then they've got a positive pregnancy test. This raises suspicion for miscarriage, ectopic pregnancy, molar pregnancy. Else, if there is no pregnancy positive test, it could be PID or some other pelvic lesions, abscesses, for instance. So, the clinical correlation in gynecology, the history, heavy menstrual bleeding, ultrasound, fibroids, the diagnosis, symptomatic fibroids. So, history, infertility, ultrasound, hydrosalpinx, possible tubal infertility. So, history, postmenopausal bleeding, ultrasound, endometrium, that is 10 millimeters, possible, that's highly suspicious of endometrial cancer. Clinical correlation, abdomen. So, patient with fever, ultrasound, hypoechoic liver lesion, possible diagnosis, liver abscess. Patient without symptoms, same lesion, possible hemangioma. Clinical history changes everything. So, clinical correlation in breast, patient age 24, oval lesion, parallel orientation, likely a fibroadenoma. Patient age 68, same lesion, needs greater suspicion, age changes interpretation. Thyroid ultrasound, neck swelling, ultrasound, mouth nodular goiter, history, hyperthyroidism, management changes. Because now history, there's hyperthyroidism, then management will change. If unlike if it's just a goiter without hyperthyroidism. Doppler findings require clinical context. Absent ovarian blood flow, history, sudden severe pain, so it could be ovarian torsion. Absent flow, large postmenopausal ovary, possible necrotic tumor, differential diagnosis. So the common mistakes that are made: ignoring the history, scanning too quickly, reporting incidental findings only, missing symptoms, not asking about previous surgery, ignoring laboratory findings, failing to communicate urgent findings. So the case study 1, clinical history, 28 years, pain, positive pregnancy test, previous ectopic, ultrasound, empty uterus, as you can see there, adnexial mass, as you can see there, free fluid, diagnosis. This is suspected of a ruptured ectopic pregnancy. Without history, the diagnosis may be delayed. So case 2, history, heavy menstrual bleeding, ultrasound, large fibroid, hemoglobin 6 grams per dl, diagnosis, symptomatic fibroid causing severe anemia, requires urgent management. Case number 3, history, fever, right upper quadrant pain, elevated WBC, ultrasound, complex liver lesion, diagnosis, pyogenic liver abscess, not a hemangioma. Not a hemangioma. So, communication with referring clinicians. Always communicate urgently when findings suggest a ruptured ectopic pregnancy, ovarian torsion, placenta abruption, deep vein thrombosis, abdominal aortic aneurysms, testicular torsion, appendicitis. Good communication always saves lives. So the structured reporting. An ideal report contains clinical history, pelvic pain, and positive pregnancy test. The findings, detailed ultrasound observations, impression, highly suspicious for ruptured tubal ectopic pregnancy. Recommendation, urgent gynecology review is advised. So the tips for better diagnostic accuracy: read the request form carefully, speak with the patient, review previous imaging, compare laboratory results, scan systematically, correlate symptoms findings. avoid premature conclusions, and discuss difficult cases. The diagnostic pills. These are the diagnostic pills. Treat the patient, not just the image. So you're dealing with the patient, not just the image. A perfect image without history can mislead. A modest image with excellent clinical correlation often leads to the correct diagnosis. Ultrasound is both an imaging science and a clinical art. Take note of that. Ultrasound is both an imaging science and a clinical art. So the final summary, clinical history transforms ultrasound from a descriptive imaging tool into a powerful diagnostic instrument. By integrating patient symptoms, past medical and surgical history, laboratory data, and image findings, sonographers and clinicians can reduce diagnostic errors, improve report quality, prioritize urgent conditions, and enhance patient outcomes. The most valuable ultrasound examination is not necessarily the one with the clearest images. It is the one interpreted within the correct clinical context. So the key take-home messages to you, ladies and gentlemen, always obtain a focused clinical history before scanning. Tailor your examination based on the patient's symptoms and risk factors. Correlate ultrasound findings with laboratory and clinical information. Recognize when similar ultrasound appearances have different meanings depending on the patient's history. Communicate agent findings promptly and provide clinical relevant recommendations. High quality ultrasound practice combines technical skill with sound clinical reasoning. Ladies and gentlemen, I think the message is so clear to all of you. Some, they think that ultrasound is only about images and their interpretation, but there is something that is beyond the images, the history of the patient, the communication that we have with the patient. At times, the patient is not so free to talk to the referring clinician. They can be free to give you more information to you that they didn't provide to the referring clinician that can help narrow down the diagnosis. Thank you so much. Don't forget to comment, share, and like. And also, if you've got questions, feel free. You can ask anything in the comment section. Then I assist you accordingly. Thank you so much.
Welcome, colleagues. How are you? So, what I am giving you now, this is the gold of first trimester ultrasound scan. I am giving you diamond fields of first trimester ultrasound scan for free. These are the diamonds, not emeralds. These are the diamonds. So this is the atlas of first trimester pregnancy failure. This is the atlas. So below are representative ultrasound appearance of the most common types of first trimester pregnancy failure. So number one, that's a normal pregnancy for comparison. So a normal pregnancy, you are supposed to see the decidual array sign, the double decidual sign, that ring that we have. And if you zoom it, you can see the yolk sac there. The yolk sac is present there. So the yolk sac is present there. So this is the standard normal ultrasound scan that you all know of. But that is so good when it is like that. But it doesn't always follow like that, that you're going to see the normal. It is the abnormal that is now a going concern. So let's talk about the abnormal one. So the unembryonic pregnancy, the blighted ovum. So here you can see there, we can't see the gestational sac, neither can we see the embryo. There is nothing there. So there's nothing there. So say the view of an empty gestational sac on a blighted ovum. So you can see there's nothing there. But we said you don't just jump and say this is a blighted ovum without measuring the mean gestational sac to be equivalent to or above 25 millimeters. As long as it is below 25 millimeters, you give it the benefit of the doubt. You can rescan it after a week or 2 weeks to see if the embryo start to develop. So this is the hallmark of a blighted ovum, an embryonic pregnancy. There is nothing. Yet the mean sac diameter is above 25 millimeters. So the embryonic demise, which is the so-called the missed abortion, the embryonic demise. So you can see here there is an elongated echogenic something that is here, that is echogenic and elongated. There is it's shrunken. So that is the dead embryo. So the embryos died there. The embryos died. You can see there. You can see the dead embryo there. The dead embryo. If as long as it is above 7 centimeters and there is no cardiac activity, then you are confident that you are dealing with a case of what? Of a missed miscarriage or a dead embryo. So you must see an embryo inside with no cardiac activity on condition that that same embryo is got a diameter that is above 7 millimeters. I hope this is percolating well and you are getting it nicely. Okay. Inevitable miscarriage. Inevitable. Inevitable. It means that it can't be stopped. It can't be stopped. So when you see that the pregnancy is now inside the cervix, is on its way out, that is an inevitable miscarriage. You cannot save that. So when the os is closed, is open, and the vaginal canal is now the cervical canal is now open, you are supposed to know that we are in the highway out. So that's an inevitable miscarriage. So now, incomplete miscarriage. So when there is an incomplete miscarriage, there are episodes, there are periods in the first trimester that someone comes, they were pregnant, they started bleeding, then they come for the sonar. You can see retained products. So returned products, they appear like that. You see that there's an echogenic endometrium thickened like that, and then you can see there is hyperemia or hyperperfusion or enhanced myometrial perfusion due to the retained products of what? Of conception. So you must not just rush to say everything that you see is a RPOs or is an incomplete miscarriage. It might be endometrial hyperplasia, it might be endometrial cancer. So the history is very critical. Was someone pregnant? Were they bleeding? Then you can talk of an incomplete miscarriage. A complete miscarriage. So complete spontaneous abortion. So you can see there that the endometrial is there and it's thin. There are no retained products inside. So this is a complete miscarriage. So do not confuse a complete miscarriage with a normal period, because with a miscarriage we must have a history of pregnancy first before someone can miscarry. Otherwise it's a period or it's another type of bleeding, abnormal PV bleeding. So now we also have got what is called the subchorionic hemorrhage. So the hemorrhage on this on the other side of the chorion, there on the other side of the chorion there is what is called the subchorionic hemorrhage. So you can see here the gestational sac there, but you can see that there's another anechoic space there, that ring that you are seeing there. So this is a hemorrhage. That's the bleeding in the subchorionic space. So the hemorrhage in the subchorionic space there, there's hemorrhage in the subchorionic space. You can see in here it seems as if the gestational sac is detached, and then there's a hemorrhage all over here. So you must take note of a subchorionic hemorrhage and the threats that it can pose to the existing pregnancy. So please, this atlas will help you. It will help you to identify those soft markers of pregnancy failure. So the irregular gestational sac. So an irregular gestational sac that is not circular in all that is another sign of a pregnancy failure. You can see this is an elongated gestational sac. Don't see this and see that it is normal, and then you record that is normal, and then you try to measure the mean sac diameter like that. No, you see how it is like. Look, this is an irregular sac. Look how it is like that. Look how it is enlarged gestational sac like that. You see this one. So what we have here, guys, now is another sign of pregnancy that is failing. So it's an irregular gestational sac like that. So also an abnormal yolk sac. You see, look at this calcified yolk sac that we have there, a calcified yolk sac there, and then you can see this calcified rim of the yolk sac there, and which is also irregular. This is also another sonographic feature of a failing pregnancy. The yolk sac is also an indicator of a pregnancy that is likely to fail or that is going to fail. So you must look at the anatomy, the architecture of the yolk sac itself, if it is regular or well outlined at the same time without calcifications. So do you guys do that? Do you really check the yolk sac and analyze it for any sign of pregnancy failure? Yes, probably 19% do, probably 15% do, probably 10% do, probably 5, probably even 1% do. Do not leave these markers. These are the silent markers. That's why you say that I did a sauna today. Then someone comes after a week, they're bleeding, they're already miscarrying. Say, what happened? The pregnancy was very normal, because you overlooked these soft markers. You did not check them nicely. So when the patient comes, then they are now bleeding and all that. Then you say, I did my job, everything was fine. You understand? That kind of stuff. You understand? It is because of that. It is because of this. So the foundation is always very critical. Without the foundation, we cannot have structures. So pregnancy of unknown location. I have discussed about this. A pregnancy of unknown location is not a pathology. It is not a diagnosis. It is a condition, a transitional condition. It's a condition that is happening, but it's just like when you wash your clothes, they are still wet. It's a transition. When they dry up, they will not be wet anymore. Or if you keep soaking them in water, they will keep on being wet like that. You understand? So the condition, we don't know where the pregnancy is. You understand? That's a condition. But after some time, you will know. It was an ectopic. Oh, it was just there in the endometrial cavity. I did not see it nicely. I did not use a TV, so I just used a transabdominal. You know, negligence, incompetence, use of outdated equipment, lack of experience are all confoundings when it comes to the diagnosis of some of these pregnancies of unknown origin. So the due diligence is to repeat. There's power in repetition. So the patient comes again, you check again, the pregnancy test is done again, they confirm the beta ECG if there are changes, you understand, to make sure that it was indeed not a pregnancy, it was a false positive pregnancy in the first place. You understand? So that's how we will get a definitive. When we get the definitive answer, now we are out of the phase where we say that this was a pregnancy of unknown. Now we know it was never there, or it was an ectopic pregnancy, or it was just an early pregnancy that was here to develop. Now it's there. I hope I'm making sense. So ectopic pregnancy mimicking pregnancy failure. So we can have an ectopic pregnancy that can also mimic pregnancy failure. There you can see there it will mimic. An ectopic pregnancy is not always a pregnancy failure because it can be a viable pregnancy, but it can pose risks. You understand? An ectopic pregnancy is not a pregnancy failure. It is a pregnancy outside the uterus. So it can, in the abdomen, if there's enough space and the attachments are fine, it can just reach term. I've seen one case where we monitored an abdominal ectopic pregnancy until the baby delivered, a healthy baby in the abdomen, outside the uterus. It's very possible. So do not confuse an ectopic pregnancy for a failed pregnancy. But though it poses far-reaching uh, consequences when it's not diagnosed as well, it's life-threatening. I hope I am making sense. So now, early twin pregnancy with a single fetal demise, vanishing twin. So this is another manifestation of pregnancy failure. You can have one fetus normal in a twin pregnancy, then the other one is vanishing or is dying. So this is another case of a failed pregnancy. We are not saying both failed, one failed, you understand? Then the other can make it. So in vanishing twin, the remaining or the residual twin just can make it nicely, you understand? So it's a partial pregnancy failure where one fails and the rest continues. So if you are not careful, you do your sonar, you see the twins, you tell your patient that these are twins, but later on when they come, you see that's one. So you are going to be seen like someone who's incompetent. You must know that there is what is called the vanishing twin syndrome, a sign of pregnant failure. Then the other one may be probably vanished. That's what a professional does. So now, this collection covers the major ultrasound appearance encountered in first trimester pregnancy failure and is well suited for teaching case discussions or ultrasound training. So this is fundamental. It is very key. Those who are teaching, those who are doing case discussions, those are training. Please, this it is looks like not big like the Rumag box, but this is the summary of the epitome of first trimester ultrasound scan. I don't know how to express it better than that. So the key diagnostic ultrasound criteria, the finding a crown ramp length above or equal to 7 millimeters with no cardiac activity is a definitive pregnancy failure diagnosis. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. Thus an unembryonic pregnancy. Mean sac diameter above or equivalent to 25 millimeters with no embryo, thus an unembryonic pregnancy. So the empty uterus after previous confirmed pregnancy. So that's a complete miscarriage. Empty uterus after previous confirmed pregnancy. That's a complete miscarriage. Then the heterogeneous vascular tissue in uterus. So that is a retained product of conception. The heterogeneous vascular tissue in the uterus, that's a sign of retained product of conception, RPOCs. So gestational sac in the cervix. So inevitable miscarriage or abortion in progress. So that's an abortion in progress. Gestational sac in the cervix, so inevitable miscarriage and abortion in progress, or alternatively a cervical ectopic pregnancy. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. Enlarged or irregular yolk sac, suspicious for impending pregnancy failure. So it's a marker that the pregnancy might fail. So you must document like that. Irregular or collapsed gestational sac. So this is a poor prognostic sign when the gestational sac is irregular or collapsed. You must take note of that, guys. It's a poor prognostic sign. So the empty uterus with a positive beta HCG, empty uterus with a positive beta HCG. So that's a pregnancy or non-location until proven otherwise. So if you have an empty uterus and the pregnancy test is positive, this is a pregnancy of unknown origin until proven otherwise. Ladies and gentlemen, besides your images or your pictures on your walls, your grandfather's pictures on your walls, I urge you to add the images of this atlas in the walls of your bedroom, so that each time you sleep, you are going to see these things over and over and over and over again, so that you don't miss anything. Someone who trained ultrasound in 1983 might have forgotten now that the abnormal yolk sac or a calcified yolk sac might be an indicator of pregnancy failure, and they've done several thousands of first trimester sonars, and most or some of the patients, they came back after a week or 2 weeks after having miscarried, and then you said everything was normal. You understand? Learning is on a continuum. Learning has to take place every time and every day. I thank you so much for your time. Please share this educational content with your colleagues and your friends. I urge you to do that for the sake of the patient. Thank you so much. Hello, colleagues. How are you? So, in this presentation, I am going to talk about early pregnancy failure. So, it doesn't automatically mean that when someone gets pregnant, that pregnancy is going to make it. It's either it's going to make it or it's going to fail, or there are going to be complications. So, here is a simplified approach to identifying pregnancy failure in the early stages. So, early stage pregnancy failure refers to a non-viable pregnancy during the first trimester. It is usually occurs before the 13th week of gestation. Ultrasound is the most reliable imaging tool for confirming viability and guiding patient management. So, ultrasound has got a very huge role in determining pregnancy failure and also identifying some of the early risks of pregnancy failure that you can identify. So, step one, when you're doing an early ultrasound scan, is confirm the location of the pregnancy. So you should ask, is the pregnancy inside the uterus? That's very fundamental. Is there more than one gestational sac? So you are now working as a professional. You are having questions that you need to answer. You don't just hold a probe without having questions that you ought to answer. So, could this be an ectopic pregnancy? So this is fundamental. This is very key. Is it intrauterine or is extrauterine? That's very pertinent. So look for the gestational sac itself. You must look at the double residual sign. Is it there or is it absent? Where is it? You should look for the yolk sac. You should look for the embryo or the fetal pore itself. Is it there? At what stage are we? Is it visible or not? So if you know intrauterine pregnancy is seen, then consider a pregnancy of unknown location, PUL. So I've discussed about that previously. You can check in my previous presentations, then you can see where I was presenting about the pregnancy of unknown origin or location. So you must exclude an ectopic pregnancy, correlate with the serial beta SG measurements, and repeat ultrasound scan if there is no pregnancy that is seen. So those are the other things that can be happening. It could be a pregnancy of an unknown location origin, then it could be an ectopic pregnancy, or you should consider beta ACG measurement, repeat the scan to make sure that the pregnancy was there in the first place. So step number 2 is assessing the viability. A viable pregnancy should demonstrate a gestational sac, a yolk sac, the embryo itself, and the cardiac activity. So you have to look at those things. So diagnostic criteria for pregnancy failure. Pregnancy failure is diagnosed when either of the following is seen: crown rump length equal to or above 7 mm with no heartbeat. So if you see that the crown rump length is equal to above 7 mm and you can't see a heartbeat, you must now think of a pregnancy failure. Or the mean sac diameter is above or equivalent to 25 millimeters with no embryo inside. These findings are considered definitive for a failed what? Pregnancy. Guys, ladies and gentlemen, write this down. This is your Bible. A crown rump length above or equal to 7 with no heartbeat. That is a sign of pregnancy. Definitive. If you measure this mean sac diameter is above or equivalent to 25 millimeters with no embryo, these are called a definite diagnosis for a failed pregnancy. I hope I am making sense there. I hope I'm making sense, okay? So step number 3, you must identify the type of early pregnancy failure. 1, an embryonic pregnancy or a blighted ovum. Ultrasound findings include a large gestational sac with no embryo, may or may not contain a yolk sac. So there might be or there might not be a yolk sac. So it doesn't mean that if there is a yolk sac, the pregnancy it's viable. Okay, so the diagnosis: mean sac diameter above equivalent to 2 millimeters without an embryo is a sonographic sign, a definitive diagnosis of a failed pregnancy. So embryonic demise or miscarriage. Ultrasound findings: you see an embryo is present, but there's no cardiac activity, and the crown rump length is above or equivalent to 7 millimeters. So don't just rush to say that you are seeing a case of a missed abortion when it's not measuring less than or equal to 7 millimeters. So you must make it a point that when you're talking about an embryonic demise or a missed miscarriage, it has to conform to those. The embryo should be present. There should be no cardiac activity, and the crown rump length should be above or equal to 7 millimeters. So now, incomplete miscarriage. Ultrasound findings: thickened heterogeneous endometrium, retained products of conception, then increased vascularity on Doppler, which may be present or it might not be present. So those are the things that you have to look into when you're considering that a miscarriage has happened. So what are the ultrasound findings? What is it they're looking at? You don't just do a sonar nicodemously without understanding exactly. You must have a map. It's just like a builder who's building a house. They have what the design. You understand? They have the plan for the house. They know exactly what to do next. You understand? It's methodical. It's procedural. So when you're doing an ultrasound scan, it has to be procedural. It has to be methodical. You understand? You don't. You have to take it stepwise. Know what to look for. Know the pitfalls. You know, so that you give a comprehensive and a correct report. So the clinical features: vaginal bleeding, passage of tissue, and the open cervical os. So those are some of the part of the history that formulates an incomplete miscarriage or a miscarriage. So if someone presents with those clinical signs, it should ring at the back of your mind that you are likely dealing with a case of of a miscarriage, one or the other, be it complete or incomplete. Also, you must correlate with the information, the knowledge that you're referring clinician and the patient is giving you. So complete miscarriage. Ultrasound findings in empty uterus, thin endometrium without retained products of conception. So there should not be any. Don't just call everything a miscarriage before there's a confirmation that someone was pregnant before. So someone might just bleed because of other causes. It could be fibroids, it could be arteriovenous malformations, it could be polyps, it could be hormonal imbalances, it could be anything. It could be abnormal periods as well. So it doesn't mean when someone's bleeding is a miscarriage. So you have to also take into cognizance the history of where is the patient coming from. Was the pregnancy test done prior, and what were the findings? So clinical history usually includes complete passage of pregnancy tissue. So now, pregnancy of unknown location, PUL. Ultrasound findings: positive pregnancy test, no intrauterine pregnancy is noted, no definitive ectopic pregnancy is noted. So it requires serial beta HCG repeat ultrasound in 48 or 72 hours. So if you don't see any sign of pregnancy, if someone is testing positive for the pregnancy, they warrant to be a transitional period where you call that a pregnancy of unknown origin. So the pregnant of unknown origin is a transitional term, after which the answer will be found. Either someone was not pregnant at all, or it was an ectopic, or it was just an early pregnant that was to develop in the normal endometrial cavity. So you must understand those things. Don't just rush to say that there's no pregnancy and then go. What about if it's too early for you to visualize it on ultrasound? and then you send someone say they are not pregnant, they go they take these other drugs and all that, saying that thing that they're not pregnant. So do not be a risk practitioner, please. So evaluate for complications. Always assess for subchorionic hematoma, free pelvic fluid, adnexia masses, retained products of conception, and signs of ectopic pregnancy. So, guys, this is your Bible. Please, when you're doing your ultrasound scan, the first trimester scan, you must evaluate those signs of complications. Is there any subchorionic hematoma? Yes or no? And you localize it. Is there free pelvic fluid, be it caused by inflammation, be it caused by rupture of ectopic pregnancy or anything? So you must take note of that. Are there adnexal masses? To quantify them. How many are they? Localize them. You understand? How big are they? Are they competing for space with the baby? So there's a lot of things that is involved to give a good report and also to save a pregnancy until the pregnancy delivered. So retain the products of conception if they are there. Then signs of ectopic pregnancy, you also have to take note of those. So now, this is a simplified ultrasound flowchart of the events or that ought to be done or that ought to be followed in that hierarchy or in that order. So now the first thing is positive pregnancy test. Is an intrauterine gestation sex seen, yes or no? Is the embryo visible? If no, pregnancy of unknown location. Embryo visible, yes or no? Is there heartbeat? Then embryo is absent. So mean sac diameter is above 25 millimeters. What does it entail? This is what? An embryonic pregnancy. So if that heartbeat is present, yes, so that's a viable pregnancy, which is very normal. If there's no heartbeat, so what are we saying? The crown rumble length is above or equal to 7 millimeters. That means what? It means that's a missed abortion. Yes, early pregnancy failure. No, repeat scan in 7 to 14 days. I repeat myself again. Look at this flow chart. Let us analyze it together. Let's do it stepwise like this. Pregnancy test is done. Is an intrauterine pregnancy or gestational 16? Is an intrauterine gestational 16? Yes or no? Pregnancy test positive. Is an intrauterine gestational 16? Now we are answering this using ultrasound. Yes, is there. Is the embryo visible? Yes or no? Is the heartbeat present? Yes or no? Is the crown rumble length above or equal to 7 millimeters? Yes or no? So you see, these are the questions that you have to flow, and you'll be answering. If you master this flow chart, it will be very easy for you to do the sequence of an ultrasound first trimester ultrasound scan. So it's like that. You have to follow it like that. If you miss any of these steps, guys, you are going to make a very dangerous assumption. Doing an obstetric scan, it sounds like something that is very easy. I've checked the uterus, there's nothing innocent. I sent the patient away, there's nothing. Oh, I saw the patient, it's a missed abortion, or it's a blighted ovum, innocent. Maybe you did not make an extra effort. The fetus, the embryo is on the other end of the gestational sac, then you couldn't see it, or the probe angulation, or you didn't use the transvaginal, you understand? So there are many confoundings. So you must be very careful when you are doing this. So this is fundamental. This is your Bible, guys. Let me repeat it again for the third time, and I need you to repeat it over and over again. So this is the sequence how you do a first trimester ultrasound scan. The other mistake that most of these people do, they come to the department without a pregnancy test. So it's not good for the referring clinic. Just send a patient without testing the pregnancy. It's a protocol. They have to do that. So that if they come with a pregnancy result, they say that I have tested positive. Then you start from there. Then these are the questions that you are going to answer the ultrasound. Is an intrauterine gestational sac seen? Yes or no? If no, then it's a pregnancy of unknown location. You don't know where the pregnancy is, but it was someone says it positive, but the pregnancy can't see it. So yes, if the gestational sac is there, is the embryo visible? Yes or no? If not visible, then what does it mean? Is the mean sac diameter above or equal to 25 millimeters? If it's above and there's no visible embryo, what does it mean? It means this is likely to be what? A blighted ovum, an embryonic pregnancy. Then, if the heartbeat is the baby is visible, is there heartbeat? Yes or no? If there's heartbeat, we are fine. That's a viable pregnancy. If there's no heartbeat, then is the crown rump length above 7 equal to 7 millimeters? Yes or no? If yes, that's an early pregnancy failure. If no, repeat scan in 7 to 14 days. Ladies and gentlemen, I have done my part. I have done my part. I have given you the Bible. It's up to you to read the verses and the chapters when you deliver this to your patients so that you can serve a patient and you can become the ethical professional in your field and in your area, in your country, and in the department where you are working. Thank you so much. Don't forget to subscribe to our channel and also notify others so that we